So what we're going to talk about today is from the start of the journey to the end. And when we're talking about a journey, it's important to know, number one, you're on one. And I'm going to tell you something. With dementia, one of our big problems is we don't even know we're on the journey until we're already on the interstate. And then somebody says, well, where's your bags? And you go, well, I didn't know I was going anywhere. Well, which direction are you going? Well, I didn't know I want to go back home. Too bad. You're not going back home. Once you're on this journey, you don't get the choice to back off and not have it. And the problem is, right now across the nation, we don't have good information about early signs and symptoms and early diagnosis. So I'll tell you the truth, in about 80% of cases, the person is already in mid-stage dementia by the time we are for sure that is what is going on, and we acknowledge life is changing. But by then, the changes are really significant, and we're already in a combat mode, and we are already in stress and distress, and we are so frustrated because we didn't know we were doing this. This was not on the agenda, and we're wanting to go back and start over, and it doesn't work that way. So what we're going to start off with is we're going to talk about planning for the journey. We're going to talk about getting a diagnosis, understanding dementia, and becoming an advocate. Because that's going to be, whether you choose or not, to be best at this, you are going to want to advocate for your person. And you've got to know what to advocate for and how to be a good advocate. Whether you're a paid person or a family member, you want to support your person in the right way. And that is not, well, if mom wants to stay at home, that's fine. Daddy doesn't like me getting in his money. You know, he said he's just going to go out of here feet first. I mean, if you let that happen, that's not advocating. I mean, that's basically just letting, quote unquote, nature take its course, but not in a healthy way. I will also tell you that only about 20% of the time are physicians diagnosing this in the early stages. Docs are missing it. They're missing it quite frequently. And so the person, even if they have concerns, goes in and says, you know, I'm a little worried. I'm not as sharp as I've used to be. The doctor will say, I kid you not, one of two scenarios. Well, you know you're 82. As though that's an excuse for why your brain isn't working well. Or, well, I can put you on something for that if you want, but I don't know that it's going to do you a whole lot. But, I mean, if you want, I'll put you on. But I think you're just, you know, I think it's all right. It's happening. It happens way too frequently. We aren't getting good assessments. We aren't getting good evaluations. So let's get started. Let's talk about different dementias. Because one of the problems here is Alzheimer's is not the be-all and end-all that we thought it was. 10 years ago, we were saying that Alzheimer's was about 80 to 90% of all dementias was straight-out Alzheimer's. We know that's no longer true. At best, Alzheimer's is probably 50 to 60 straight-out Alzheimer's disease. But we're learning more about the other dementias. What we want to do here is figure out that when dementia starts, it's not an all-or-nothing thing. The first time you often notice that something's going on is when the person gets sick, or they're in the hospital, or they're not feeling well, or they're out of their regular environment and their regular routine, like you take them on vacation, or they're visiting you, or something like, and you sort of have these moments of, whoa, what is going on? What did she just say? Well, she asked about Daddy, and Daddy's been dead for 5 years. What did that come from? Or, you know, who told you that you could, and you're like, whoa, Mom, calm down. Don't tell me what to do. And then you're like, she says, well, I'm sorry, I didn't mean to yell at you, but you're just getting in my business. And you get this little fluttery business, and you're going, whoa, man, what's going on here? But then you turn around, and everything seems okay, so you go, oh, well, you know, that's just getting old. No, that's an early warning sign. I will also tell you that it's so inconsistent that it's hard to get your head around the idea that it's real. Because it comes and it goes, and it comes and it goes, and it comes and it goes. And particularly there are three folks who might pick up on the early signs. Number one, the person themselves. About 50% of the time, the person with dementia actually knows early in the disease something's up. I can't think of the, I know this. It's just, what's wrong with me? Unfortunately, by the time the rest of us figure it out, they're past being able to recognize it. If I have a problem, I'll tell you who it is, and it is not me. I'm fine. You're the idiot. And you're like, whoa. What happened to the I had a problem situation? Well, what happened is a new part of the brain is being damaged by the disease. It's spreading. It's not where it was when we started. The second person who might pick up on it is somebody who's with the person a lot. And so what they do is they notice the good day, good moment, bad moment, these odd little blips in the radar screen. They pick up on that. But when they mention it to anybody else, everybody else says, well, I didn't see anything. I think you're being hypercritical. I mean, I think you're stressed. I think it's just you being stressed. I think they're fine. I mean, because I don't see it. And so you go, okay, well, maybe it is me. And the doctor even says to you, I think I'm more worried about you than I am about your dad. And you say, okay, well, all right. You back off. The third person who might pick up on this is a family member who visits only every now and then, but stays a while. Now, you can't come and go real quick, because if you come and go real quick, they perk up and fly right while you're here. But if you stay for a couple weeks, all of a sudden you're going, oh, crap. I mean, what is going on with Mom? She put salt in the cake instead of sugar. And when we ate it, she said, well, that's just the way it tastes. I mean, I don't understand what where's her money? She took that tack notice and just put it in the drawer. But you only notice it if you stay for a little bit. If you're just in and out, they can cover. And they will cover, because they're scared they're going to get caught. And this is serious stuff. People don't want to get caught. I will also tell you that in the beginning, it's not even dementia. In the very beginning, it's called MCI, mild cognitive impairment. It means something's going on. It's not normal aging, but it's not specific enough to be anything else. It affects life, but it doesn't destroy life. So you'll find that people are often religious about their calendar. I mean, if it's not on the calendar, it doesn't happen. They do their meds, check. Don't. Now tell me again, what time are you coming? Tell me again, what time are you coming? They check and recheck and check and recheck. Or, well, I forgot all about that. I'm having a senior moment. Isn't that something? Well, you'll have to be my memory. Okay? And it's the little stuff. It's either going to be in the area mostly of memory, which is short-term, immediate recall, not long-term memory. Just recent stuff, new stuff you're trying, appointments, ways to go places, what they agreed to, things like that. Or instead, it might be in language. They can't think of the, where you put one after the other and you get them in a line and there's a whole bunch of dip at the end. Shoot, I know this. I can't think of words. Or, what do you mean I'm to roll over? I don't like rolls. And you're like, what is this? What are you talking about? Where they mistake the word roll over for something to eat. Their comprehension is impaired. And it's usually 1 out of 4 words. So it could be a word comprehension problem. And so they start talking off base and you're like, where did she get this idea that I never told her I was coming this Thursday. I told her it was next Thursday. I don't know where she got this. The other thing you might see is the behavior change. They just aren't themselves. So they're either less out there, so they aren't going out. They're staying in the house. They're missing things. They don't want to. I put enough time into this. I'm not going to do it anymore. Or they get repetitious over and over. They keep doing the same thing over and over. And it's like, Dad, you already took care of that. Well, I was just checking. Okay. Or what you notice, motor skills change. They are not as sharp and quick as they were, so they're getting little fender benders. They're making little trips and slips. They're falling and they get bruised up, or they're having trouble with doing the real detailed stuff. You notice their handwriting isn't as neat and whatever, or they're spilling things. They're dropping things. They're having problems trying to do 2 things at the same time, like carrying in groceries, or moving things, carrying laundry from one place. They trip on the first step of the step, or at night more than during the day. Okay? So these things are different, but they're not life-altering. Now, this is the Alzheimer's Association 10 Most Wanted list. These are the things you want to look for. Memory loss for recent or new information repeats themselves. Now, it could be they repeat questions. What time are you coming over? What time are you coming over? What did you say you were going to do? Or they might be, did I ever tell you I was from West Virginia? I did.
I forgot I wasn't supposed to say that.
Yeah.
I'm
sorry. I won't do that again, right? Notice how you caught yourself. Yeah.
I did.
You know what to do.
Yes, I do.
Yeah, now you know what to do. But they tell you the same old stories over and over, or they call you over and over to tell you the same thing, and it's like, Mom, we already talked about this. We did? Well, I don't remember talking. Who did you talk to about it? you? Well, I don't think we talked. When did we talk about this? Or they catch it and they go, oh, well, I know that. What did we say? And you know they're covering. You know they're trying to protect their identity, but they're having trouble. Difficulty doing familiar, difficult tasks. Managing money, it's often not just going out and using money. It's when they get something in the mail that's really not a bill but sort of looks like a bill, and they'll pay it. They'll send money to post office boxes in Oklahoma. If it says, this is your last notice, you will have this turned over to a collection agency. And people will do it, even though they didn't have anything. They will also take their tax forms and just hide them rather than trying to figure them out. They will have difficulty with investment. They'll be making bad investment decisions. And people take advantage of that, by the way. Medications, they often do okay with regular medications. It's the new ones, like an antibiotic. They won't take it like they're supposed to. They'll have trouble if the doctor changes the dosage or the frequency. They can't get into it. They will actually double dose themselves sometimes without realizing it, or skip doses completely and not realize it. And you'll say, well, Mom, you still have 30 pills. I thought you'd been taking these all month. Well, I have. That's another bottle. See, I don't take that bottle. I take the other. And it's like, if in your mind you're going, ooh, man, something's funny here, probably something is funny here, okay? Because we miss this. Driving, they are either hyper-attentive driving and hyper-vigilant, and they repeat, if they're going to have a doctor's appointment, they want to go out the day before, and they want to check it out, and it takes them forever to do things. Or they're very dicey when you drive. You're going, oh, pedestrian, Dad. Oh, he's right. Oh, he's walking. Dad, brake. It's called passenger seat driver. I mean, basically, you're taking over the higher order skills in driving to compensate. They can't do it all. They simply can't go back and forth and do that kind of thing. Problems finding words. Either they come up with the wrong words or they don't quite understand. Get confused about time and place. So they're getting lost while they're driving. They end up in Orlando when all they wanted to do was stop in Tampa. They end up going down to Fort Myers. And you're like, Mom, what are you doing in Fort Myers? Well, I was going to the store. Well, why didn't you just go to the one down the way? Well, they have detours set up. But I don't understand why you went to Fort Myers. You don't need to know why I went to Fort Myers. You are just too nosy. And they get ornery sometimes, or sad or upset. And it's all about being scared. Worsening judgment. They can't think things through. That not problem solving. This is where if you are trying to help and you say, well, why don't we bring somebody in? No. We don't. I don't want somebody in my house. I don't need them. They're a waste of time. I'm not going to waste my money that way. Even though it would allow them to be more functional, they can't see that. You just can't get them. And even if you're trying to do it, they see you as an opponent rather than a helper. Misplacing things, putting them in odd places, and sometimes accusing you of stealing them or others of stealing them, taking them. Changes in mood or behavior, changes in personality, and this is the one, withdrawal, a lack of initiation. These folks are not doing what they used to do. They say, well, and they'll make up excuses. They'll say, well, I've given enough time to the church. I'm just not going to do it anymore. I don't feel well. I'm not going to go today. I'll do it later. And what you start picking up on is they're hardly doing anything. They're hanging around the house, and you say, well, what did you do today? I've been busy. And like, what was it? Well, I don't know. Okay. Now, having said that, I want to be careful. And the reason we want a good evaluation is because not everything that looks like dementia is dementia. It could be dementia, but it could be another health condition that's getting out of control. Heart disease, breathing problems, sleep disturbance. All kinds of possibilities that make your brain not work right. I would also tell you that it could be a medication side effect. There's 14 classes of medications that as you age could actually impact your cognitive function. Hearing loss or vision loss. Problems with depression, delirium, or possibly pain. Particularly people who've been on pain meds for long periods of time, anxiety meds for long periods of time. It may actually affect how their brain works when they get older. You know, you could maybe take Valium when you were younger, Ativan when you were younger to control that anxiety. As you get older, why did you come in my house? And it's like, whoa, take it back a notch. I mean, you're the one that signed the agreement that I could come in your house, but not so much, okay? The two mimics you really want to know about, delirium and depression. Delirium is a rapid, very quick change in function. They were one way on Friday. On Saturday, they look totally different. They are seeing things. They're bring it down. Put it in the. Got it now. Let me get that. Woo! Who are you? What are you doing here? Oh my God, I'm sick. Oh, I've got to lay down. Oh, hey, how are you? Get out of here! Whoa. Now, the most common causes for delirium in older adults are infections. And the number one is a urinary tract infection. But it could also be an upper respiratory infection. It can be a whole variety of things. It could be COPD getting out of control. It could be problems with congestive heart. It could be medication problems. But it's something that we need to pick. It could be little strokes. It could be double dosing on your meds. But I'll tell you, when you see a delirium, you should think emergency, emergency, emergency. And you've got to advocate. Because what we know across the country is people are going into the emergency rooms and being sent home on Ativan, Zyprexa, Haldol, Risperdal, Seroquel. They're seeing the symptom of agitation, which comes with delirium. But what they're not realizing is it's a sign and a symptom of an underlying problem. And if we don't advocate, people don't get what they should get, which is an excellent workup to figure out what is causing this. People don't suddenly change with dementia. That is not how it works. There's something else going on. Now, it can be as simple as having a caregiver out of town and having nobody familiar around me. And I don't understand what's going on because my dementia is getting a little bit worse. But it can actually, and in most cases, is something physiological or physical. Could be I have sleep apnea. Could be my vitamin B12 is deficient. I mean, it can be all kinds of things. But what happens is people go in the emergency room and they just dose them up and send them out. It happens so regularly, it's not even funny. The second one that we really want to pay attention to is depression. It's called a pseudo-dementia. Both of these are pseudo-dementias, not the real deal. Depression comes in two forms. It comes in the, oh, just let me lay in the bed. I know I've peed on myself, but I hurt. I don't want to get up right. Don't turn the light on. Please leave it off and leave the covers over me. No, go away, please. Please just leave me be. I don't want to, honey, just tell the people from church to stay away. I can't take this anymore. Just go on. I'm not hungry. I'm tired. I've got to rest. Please get out of here. Leave me alone. Just let me be. That's the sad immobile depression. Change in appetite, change in sleep pattern, change in self-care status, no pleasures, emotionally either flat or down, negative. Those are all signs, and it takes weeks to months for that to build up and happen. But what happens is if you have an overlay of a little cognitive impairment, and that goes on, everybody says, oh, it's just dementia. That's their dementia. No, it isn't. That's depression and dementia. It's both, maybe. To treat depression, we need a three-pronged approach to be successful in older adults, particularly older adults who have some dementia. Number one, we do need a medication that's appropriate for their depression. Second, we need activity. We've got to get them active. We've got to get them engaged. We've got to get them doing stuff. Because the meds don't do anything if you don't then move. You've got to get them up and moving. And they're not going to like it at first. So don't try to engage them in things they like, because they're not going to want to. They're going to say, bullshit, let me sleep. This is ridiculous. And so you want to pick things that they don't really like to do. But I'll tell you what, you work with me 5 minutes, I'll leave you be. Fine. I know you don't like this. I'm sorry. I hate bothering you, but I'm going to. I know you are bothersome. Don't expect them to be nice. They're not going to be nice at first because they're depressed. And the third piece of this puzzle is that we need talk therapy. The hard part is finding anybody who's willing to talk to somebody who has an underlying diagnosis of dementia who's also depressed. Because the people who normally treat depressed people want them to carry over from session to session. I don't even remember I've seen you before. And so the challenge is finding that right mix. Somebody who's willing to do talk therapy with somebody who can't remember. But there's still talk therapy that's valuable for these folks. They still do well with talk therapy, but you just have to give up the idea that there's going to be carryover. And that's a hard thing for the folks in the psych community to get around because they've never had to deal with it before. I mean, that's when you give up on somebody if they can't carry over session to session. Duh. They keep forgetting there's dementia in addition. Now, the other kind of depression is a little bit different. Who told you to come here? Did I ask for help? No. And let me tell you something. You get your ass out of my house. And I'm going to tell you something else. You stop by Burger King and buy me French fries And I want 3 million. Don't tell me I'm diabetic and hypertensive. Bullshit. You get what I asked or I'll break your neck. Do you hear me? And I'll tell you something else. I'm going to stay up all night long. I will be up all night long. And let me tell you something else. I'll be up all day. Don't you tell me what I'll pee off the front porch if that's what I want to do. I'm running about naked. You tell those people from church, they come over, I'll knock them on their ass too. Do you hear me? And you're like, whoa. Whoa. Now, first call to the physician is not going to be, gee, I'm concerned mom's depressed. It doesn't happen. What you're going to say is she's agitated and aggressive. And what's going to happen? She's going to get her symptoms treated. Haldol, Risperdal, Seroquel, Ativan, Geodona, Abilify, Zyprexa. She's going to get a medication to manage the behavior, but we never even look to see what caused it. Change in appetite? Yeah, but instead of not eating, she's eating a lot of junk. Salt, fat, and sugar are the common ones. Second thing you're going to notice, activity. Change in activity. Oh, yeah. Change in sleep. Oh, yeah, I'm up all the time. I have a hyperactive. It's called an agitated atypical depression. The bad news, people who have a tendency toward dementia have about 50% are sad and immobile, and the other are active, agitated, mean. And the problem is, guess what they respond to? Same 3. Guess what they don't get? Any of them. The meds they get are not the right meds. The management they get is not the right management, and we never even do talk about it because we want them to quit being like they are and behave themselves. And unfortunately, we missed the boat. Here's the bad news about both of these. People who have one or the other, we want to check it out. We know that people with delirium in a hospital setting or in a home setting, when they go in the hospital and they become delirious, they have a much higher risk that within 5 years they will develop a full-blown dementia than older adults who go in the hospital who do not develop a delirious episode. It's a very high indicator of a vulnerable brain. We also know people who suffer from depression are 50% more likely than their peers to develop dementia at a younger age. And we're finding the same is true with other major psychiatric illnesses. Schizophrenia, bipolar disease. People with those conditions start showing dementia sooner. And there's something about the chemistry of the brain that sets it off at a much younger age. And it's called dual diagnoses. Okay? Now, this is a list of the drugs that might affect your cognition. Let me just read through it. Antiarrhythmic agents, things that control the rhythm of your heart. Antibiotics you take when you have an infection. Antihistamines and decongestants you can buy over the counter. These are things that when you have a cold or you have allergies, you might take them. Tricyclic antidepressants, especially some of the older ones. Antihypertensives, including Lasix, can affect your brain. Anticholinergic agents. 2 of the biggies that you need to think about, anything with Benadryl in it, which includes Tylenol PM, and cold things over the counter, and allergy things over the counter, and Detrol LA. Detrol, the reason it keeps your bladder from squeezing too fast is that it has anticholinergic properties. Acetylcholine is what makes your brain work right and remember and learn things. So what we're doing is we're giving you a drug to help your bladder to relax, but it's making your brain not work right. Now, there are other ones within that class of those, and they're newer ones, that don't affect acetylcholine level at all. But guess which ones most docs are putting people on? The old familiar. And what we have to do is we have to say, whoa, 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 hang on, time out. I'm an advocate for my person, and I would like us to switch out. I would like to try the other one instead. Anticonvulsants, antiemetics, histamine receptor, immunosuppressant agents, anybody who has lupus, who has RA. This includes people who have had cancer and are on medications afterward, and maybe had radiation, had chemotherapy. Their brains may be damaged and may actually be struggling with how to function because of the chemical changes that came on, chemo brain. And it's a dementia-like condition. Yeah?
Do you have a similar list for supplements?
They're starting to put together a list for supplements. One of our big challenges with supplements is that there's not a regulation that they're all made the same way. And so some have more than the other because the Food and Drug Administration is not in charge of them. And so their creation and their consistency is highly variable. So, like for instance, the red rice yeast. I always say red rice yeast. When it comes from China, you got to be real careful because it has potential to have a high lead content in it. And that's, so you want to know where your sources are, because how they make theirs, how they construct theirs is not necessarily safe. And so that, I mean, some of that really comes in because there's not regulation on it. I mean, there's no regulation on it. Muscle relaxants, narcotic analgesics, sedative hypnotics, and anti-Parkinsonian agents. Yes?
The antihypertensive, I mean, it's like most older adults.
You think?
Oh,
Sure enough.
High blood pressure medicine.
No. Really? When did that happen?
So what's the alternative? Lifestyle change or what?
Well, it is lifestyle, but it's also looking at your antihypertensives and which ones have the least impact on the central nervous system. And knowing that we have to monitor carefully, and then when somebody's showing us some signs, not to automatically go, oh, well, she's got dementia. Well, maybe not. Maybe her medication needs to be adjusted, because what we're seeing is a change that we need to take care of. And so we say to the doc, hey, I know her heart is working great, but her brain has really deteriorated here. So we need to go back and relook and recheck. Docs become specialists sometimes, and they focus on one organ system, and they forget they're all connected. Your brain, your heart, your gut, and your bladder are all neurologically very connected, and what you do to one can impact the others. But many specialists focus on the one, and they don't go back and look at the whole picture. And one of our big problems is they never took a baseline measure of what your cognition was to start with, so they don't know there's been a change because they never even looked to start with to see that what it was to start. They don't know what your thinking skills are to start with.
Would blood thinners be an outlet?
Blood thinners, yeah, Coumadin is a high-risk one for cognitive impairment as we get older because our blood vessels are more fragile. And it's not that you don't want to be on it, but we want to take a measure of your cognition and keep track of it over time. So if we start to see a change, we go, whoa, hang on. I think we need to look at this. Would you ever take Coumadin, a blood thinner, without doing blood tests every now and then to see what the levels are? Why? Why do we not take cognitive measures and look at what's going on to the brain when we add all these drugs to it, knowing that on average an older adult over the age of 70 is on at least 3 of these? At least 3. And we never measure their cognitive at start, so we don't know whether they've changed. And so when they change, what's the assumption? They got dementia, they're getting older. You know how it is. There's a lot of assumptions made about aging and thinking. Here's the basics on medications when you have older adults that we should be doing and that are not happening. This is where you need to be an advocate. You have got to be a better advocate than we are at this point. With medications, the rule is you start low and go slow. If we're going to make changes in meds, we want to start low and go slow. That is not the standard. They want to bump them up real quick, see how it's working. And even the Aricept, the Exelon, the Razidine, those packages are actually designed for a 2-week startup. 2 weeks and you're good to go. A month, you're solid. Sometimes with people who have nervous stomachs, who have problems, what we may want to do is start even with half of half and take twice as long to come up. They might have less problems with diarrhea, nausea, vomiting, and then what happens when you have nausea and vomiting when you take a new medicine? I'm not going to take that. It's ridiculous. It doesn't help, and I feel awful. I'm not taking it, ever.
My father flushed his Aricept down the toilet.
There you go. And so now I'm going to come back and try to talk you into it again. That's not working. I don't need it anyway. There's nothing wrong with my thinking. You take it if you want it. Okay? And the problem is, if it's a negative experience, it really adds up. So we really want to look at that. We want to do one thing at a time. Making 3 changes in medication at a time, you don't know what did what. And you may think one thing happened, and all they had was diarrhea because of the first medication. They got dehydrated, and so everything else you saw was related to the dehydration from the diarrhea and the vomiting. It was because they were dehydrated. It wasn't even the medication at all. It was just the outcome, the side effects. We want to take away before adding on routinely. Our goal is to take away before we add on. On average, older adults in this nation are on approximately 10 medications a day. 75 and older, on about 10 meds a day. That's too many things going on in a system that's already fragile. We also want to watch and match the symptoms that we're trying to treat to the meds we're given, and we got to look and see, did it work? Did it work? People have been on Detrol LA. And I'll ask the question, I'll say, Well, so is the frequency any better? Well, no, I can't tell any difference at all. Well, how long has she been on it? 2 years? Well, why do we have, well, I don't want it to be worse. And it's like, well, it's not really a preventative thing. It's really a treatment thing. And if you're not seeing a change, it's probably not doing what you wanted to. Let's back her off and see if you see any change in function. If you don't see any change in function, let's get rid of it because it has potential to cause problems. And if our attitude were more let's minimize, versus here's another pill, here's another pill, here's another pill, which gets us in trouble the older we get. Be aware of potential side effects, because a lot of things people take have potential side effects that you might actually think it's dementia, and what it is, it's a side effect of the med. And we want to keep track what's happening in a med log. And online, we will also put up some samples of med logs, behavior logs, appointment logs, so that you have those things. So you can use those as you're trying to help your person. It's much better to keep track of things regularly than when there's a crisis and you go, well, now when did this start? Let me think. If you're keeping up with it all the time, when you talk to the doctor, here's how I kept track of things. Take a look. Doctors are much better at paper than they are people sometimes. You give them a piece of paper with everything on it, they'll go look at it. Oh, wow. If you try to talk to them, let me take a look. And what happens is you don't get listened to. And it's critical that you get listened to. We also want to think about what is out there. And there's not a lot, but there is some stuff to look at. There are meds for thinking changes. What we know about them, the earlier the better. The Aricept, the Exelon, the Razidine, if they're going to help you, they help most when you have the most brain tissue still active. As this disease progresses and there's less and less brain tissue active, it's not going to give you much bang for the buck. It doesn't change the disease at all. All it does is make more acetylcholine available in your brain. That's all it does. It doesn't change anything. It doesn't actually hype your brain up by changing it. What it does is make more chemical available. It actually will not work in some people. We don't know who's who, but we know in some people it doesn't actually work. But we don't know who that's going to be. We can also say that with Aricept, Exelon, Razidine, the acetylcholinesterase inhibitors, keeping people not getting worse may be our goal. It's not getting better. It's just not making them drop so fast. They're going to end up at the same place. It's just how they get there. We also know that there are a number of meds that are used to manage behavior. Sometimes these meds are necessary for short periods of time. When you've tried everything else and it doesn't work, it doesn't mean people need to be on them long term. And what happens is people get put on these meds and then we never actually back them off. And all the meds that we're talking about in that ballpark have side effects that are pretty significant. All the antipsychotics increase risk of falls, increase the risk of dehydration, increase the risk of somnolence, increase the risk of dislocation, inability to socially communicate. It may actually affect the fine motor skill in your mouth. Swallowing, chewing might be affected. So it's not an easy decision. It's a balancing act when it comes to this stuff. Now, let's talk about dementia. What is it? Well, there are two pieces that take place when somebody has dementia. There's structure changes and there's chemical changes. And the chemical changes happen first. The chemistry of your brain actually changes before the structure of your brain changes. What's going on is when dementia hits, it literally causes your brain cells, certain dementias, particularly Alzheimer's, it causes your brain cells to put out less chemical. They can't produce as much acetylcholine. They're slowing down. They're being damaged internally, so their acetylcholine production, their chemical production is reduced. They don't put out as much. Then what starts happening is the structure starts being affected, and they literally start shriveling up and shrinking. Now, a brain cell is very complex. It has a body, and it has lots of arms and legs going off, known as axons and dendrites, going off of it. And each axon has thousands of little, tiny connectors that reach out. Put your hand up for just a second. And they almost touch another brain cell, but not quite. This area is where we exchange chemicals. I send chemicals, and she gets them. So this is a synaptic connection. So my chemicals actually shoot out here and latch on to her, and then she gets excited and she can send a message to the next person. With Alzheimer's, particularly, what happens, I'm producing less chemical and I'm actually shrinking and shriveling back. So I shoot chemical out, but it has a greater distance to go to get to the next brain cell synaptic connection. I'm also not producing as much. Now let's say that my friend here, there were 2 synapses. And when I first started, it was real clear which synaptic junction I went to, isn't it? But when I shrivel back, sometimes it might go there, but sometimes it might go over here. Now what's going to happen? On a good day, I know she's my daughter and I know why she's here and I know what I'm doing. On a bad day, who the hell is she and what's she doing in my house? I only have a 3-year-old. Because this is an old memory, and that's where the connection made. And it's not a choice I'm making, it's just the chemistry of the moment. And it's happening because of the brain failure I'm experiencing. So it means the light switch is on, the light switch is off. The light switch is on, the light switch is off. I will also tell you, as I'm pulling back and pulling away, unfortunately, what used to happen is when I shot my chemicals and they hooked on, you can relax. What would then happen is that there was an enzyme that was produced. And that enzyme actually came up here and ate that chemical connection away so that she could get another message the very next time I wanted to send a message. And the chemical, the enzyme that ate it up was called acetylcholinesterase. You try to say that fast 3 times without practice. Now, unfortunately, when the disease hits, I don't produce as much chemical, acetylcholine. But my brain's ability to produce acetylcholinesterase, fine. No problem there. So I shoot my chemical out, trying to get it over there, but before it can get there, the acetylcholinesterase locks on, and the reaction never happened. So it actually keeps me from sending messages. What Aricept, Exelon, and Razidine do, and this is all they do, they don't change what's happening to me, the brain cell, or how much acetylcholine I can produce. It doesn't change the disease at all. What it does, though, is it produces fake acetylcholine. It's decoys. It's fake stuff. It's hanging out here. Looks like acetylcholine, but it's not acetylcholine. It just looks like it. It can't actually send a message. But what it can do, when I shoot mine out, the enzymes hook onto the fake stuff, thinking it's the real stuff, and I get through. Ta-da! So it makes more acetylcholine available by tricking the enzymes into locking on to fake stuff so I can send messages. Now, has it changed the disease at all? Not a bit. Am I still getting dementia as fast as I ever got it? Yes. Now, as the disease moves through my brain, at first it may be helping me remember names or words or what you just said. But as the disease moves forward, now it may be helping me remember, how do I say that word? What is the difference? What kind of chocolate? I like chocolate, not vanilla. It might be helping me be able to remember to put my feet under me when I go to stand up. It might be what's reminding me to bring my hand to my mouth to take a bite or how to chew. So it's not that it's helping me with memory. It may be helping me with motor memory at the end. So as the disease progresses, how it helps changes. But it's not changing the disease. Not all dementias are the same. Dementia, there are 70 to 80 different types, causes, and forms of dementia. 70 to 80. The most common, Alzheimer's. But look under the umbrella. What we have is 70 to 80 different ones. We have Alzheimer's. We have young onset and normal onset. We have vascular dementia. We have Lewy body. We have frontal temporal. We have genetic syndromes, metabolic, alcohol-related dementia, drugs and toxin exposure, white matter like MS. Mass effects like tumors or metastases to your brain or normal pressure hydrocephalus that's been untreated. Depression or other mental conditions, infections that cross the blood-brain barrier, and Parkinson's disease. 40% of people with Parkinson's will develop a dementia. 60 will not. 40% of MS will develop dementia. 60 will not. Okay? When we say someone has dementia, we are not actually giving them a diagnosis. It is not a diagnosis. It's a syndrome. It's a collection of symptoms. It means 4 major things. When I say someone has dementia, there are 4 things that are absolutely going to be true. Number 1, there's at least 2 parts of their brain that are dying. At least 2. Maybe more, but at least 2. Can't be a single part. Got to be at least 2. Second, it's progressive. It's going to get worse. There's nothing we can do to stop it. It will get worse. Over time, it is going to destroy more and more of their brain. They will have less and less ability. Number 3, it's chronic. I can't fix it. There's nothing I can do to make it go away. We don't have a way to either halt it or turn it around right now. No dementia is resolvable. Once it starts, You're on the bus. And fourth, it's terminal. It is going to kill that person. If nothing else kills them first, it is a terminal illness. The problem is it's so drawn out that we forget about the terminal. Doctors don't talk about the terminal. And so when the terminal comes up, it's like, oh my God, I didn't know this. So you people are not taking care of my person right. See, if you would just help them get up and walk, they need to walk. They need to walk because they're tightening up. If you walk them, they're not tightening up because you don't walk them. They're tightening up because their brains are dying. And the motor strip in your brain is what makes you relax your muscles so you can stand up and move, and it's not happening anymore. The motor strip is dying. They're not eating because they don't not want to eat. Their brain doesn't recognize the need to eat. They have no appetite. They have no thirst. And even when they try, they don't have a good swallowing mechanism. They're not safe to swallow. So the brain says, don't put that in here. I can't swallow it. They don't know how to chew. They can't fight infection because the ability to fight an infection has to come initially from where? Your brain. Your brain has to go, oh, gee, an infection. Let's do something about that. Come on, white blood cells. Come on, guys. Let's go. Come on, come on, come on. That's why they don't get big fevers. They don't get fevers. The brain doesn't go, oh, gee, infection, got to do something about this. We put them on antibiotics. They get a little bit better on the antibiotics, but as soon as they come off the antibiotics, here we go again. And that's because the brain is dying. It is dying. Okay? Now, we have lots of different kinds, and in the handout that if you want to look online, you'll be able to see all these different kinds. What I want you to realize is this disease destroys brains, Alzheimer's particularly. What we have here, and these come from the University of Alabama, work done by Dr. Richard Powers' group. What we're looking here at autopsied brains, and we are looking at a man's brain in this particular situation. We have two men. This gentleman over here and this gentleman over here, same age, same physical size, and same measurement around the skull. The only difference between these two brains, this gentleman over here died with a perfectly healthy brain, and this gentleman died over here at the end of Alzheimer's after living with the disease for 10 years. The estimates are your brain will shrink down to approximately 1/3 its original size by the time you die. You lose 2/3 of your brain tissue. And the space is filled up with fluid, cerebrospinal fluid. So you have a very small brain inside a hard brain case. So I'm going to give you two real important things. Falls are seriously dangerous because what happened before is your brain just barely fit in there, and so when you moved, it stayed with the brain case. Late in the disease, people can have a minor fall and have major damage because their brain is shriveled down. And now when they fall, the brain swings forward and hits the front. And then it swings back and hits the back. Then it swings forward, called contre-coup injury. You see it in head injury, motor vehicle accidents. But the other problem that happens is you can actually shear tissue off because of that backward-forward movement. They can actually tear neurons loose. And they can also have bleeding. That takes a while to figure out because if your brain is close, we would see it real quick because there'd be this clot of blood forming up and it would press on the brain and we would know right away. Late in the disease, people have a lot of slow bleeds. And you know when they fall, you weren't even aware they were falling because they fell when you didn't observe them and they got back in the bed. And they didn't even notice anything was wrong. They didn't remember they fell. So it's only 3 days later when instead of walking that now they're or that you're suddenly going, God, something's wrong. What's wrong with them? But by then, the process has progressed far. But it's nobody doing something wrong. It's really how the disease is. And that's the challenging part for us. And what I want to show you also in this picture, we can't even see where it all started, which is the memory center. We're looking at the cortex, the surface of the brain. The memory center, if you put your fingers to your temples, tip your hand up and shove in 3/4 of an inch, don't really do that. But I mean, figure out, because that would be really bad. I don't really want to see that happening to you. But if you push in like that, what you would realize is that's deep inside your brain. I'm not showing you that. Look at the amount of damage all over the brain. And just as a quick review, put your hand to the front of your brain. Front of your brain is what controls your impulses, makes you think, makes you be the person you want to be, gives you values to live by. It's your executive center. It's your control center for everything that you do and think about. This is the part that makes you you. It allows you to control your impulses. Down deep right in there, that's where your amygdala, that's your impulse for eating, your impulse for sex, your impulse for saying that. So you say, hey, you fat one, come here. You wouldn't do that if you had that control, but this is a part of the brain that's very vulnerable. So people say and do things they would never do. Okay? Then put your hands to your temples. Now drop the left, drop the right one. Think about this. I know, I'm looking at you getting all confused. I'm not good with left and right. Good thing I have other skills. Keep your left one up there. 98% of the population have formal language processing in the left temporal lobe. It's only on the left, not on the right. What is over here? Vocabulary, comprehension, the ability to actually say the words that you want to say to get your needs met, to put sentences together, to express your thoughts, your values, everything you want to say. Your ability to speak is actually located over on this side in the temporal lobe, frontal temporal area. On the right, however, preserved. Alzheimer's likes the left more than the right. Most of the aphasias like the left more than the right. So what we see is damage over here, not damage over here. This is preserved. They still have this. So when you think right, think this is the side they still have. This side of the brain is not attacked as horribly with these folks. So what do they have? Automatic social chit-chat. Well, hey, well, I never. Isn't that something? Well, hey, sweetheart, how are you? Well, aren't you something? Well, that's amazing. Well, hey, well, oh, my Lord. Well, how have you been? Don't you look nice? Well, that's wonderful. Uh-huh. So when you take them out to a faith-based place, everybody goes, oh, well, she looks lovely. I don't know why you're thinking of doing something. It's like spend time with her. You'll find out. I mean, because that social chit-chat, it's called a patina. They have a light patina. And that can be preserved very late into the disease. But if you make them angry or you upset them, you can also have on the way out of the church, that was the stupidest damn sermon I think I've ever heard. Idiot. And you're like, Mom, you can't say that to him. I sure can. Watch me. It's just that put this together with this and that, and all of a sudden I'm saying things I should not, but I also can be absolutely lovely. But it can be unpredictable.
It's why they perform very well at the doctor's office.
Absolutely.
And what
they're glorious, and you're going.
What you're speaking about, the doctor's saying, what are you talking about?
Look at her. She's fine.
She's on a perfectly normal conversation for the 10 minutes
that the doctor sees them. Yeah, that's why those logs come in so handy, and you say, time out, doc. And that's why you have to find the right doc for the right care. Now, here's the other thing they have on this side, rhythm. Rhythm of speech, and actually all rhythm comes from that right-hand side. So this is why even late in the disease, and you put man, and begin a man, and you go down again, and you put down. And you get better, and you get better, bam, bam, bam. You get it? You heard it? Yeah, bigger bit. Now, my content is crap. I'm having real trouble with formation of words. Notice how slurry everything was. But I absolutely have rhythm. It sounds like I'm talking. And so your brain is going, huh? What'd you say? And if you're not careful, you say, Mom, what did you say? What did you say? You put it down, you put it down. Now you make me angry. Because I'm doing the best I can. I can't get the words to come out any clearer. But I'll be, well, hey, sweetheart, how are you? And that really throws you because some kind of things come out so clear. You're like, my God, if she can do that, then she can do it. And they usually do it with people they don't know. Not with you, because you're old hat. But they're exciting. Okay? The other thing that's on that side is music. Rhythm and music. So they can sing. They can't talk. They can sing. Don't sit under the apple tree with anyone else but me. And somebody who never talks. It's like, they're singing. You're like, son of a gun. Now that's the blessing and that's the gift. Because what I'm going to tell you is after they sing for a little bit, sometimes they can talk better. Because you use what they still have to compensate for what's missing. And sometimes it spreads over to the other side of the brain. And if it's not totally gone, they can talk for a little bit. Won't last long, but it can happen. The other thing they have is prayer. They can do prayer. Because if you think about most prayer, it's long term, which we have, but it also is, Our Father. What's the next phrase? Who art in heaven. Hallowed be thy name. Think about it. There's a rhythm to it. It's all done with rhythm. The Lord is my, I shall not. Yeah. Think of how many books of faith have a lot of rhythm in them. And they also are very good at hymns that they grew up with, or songs that they grew up with in their church or their faith or whatever it is that they come from. Old songs are best. You want to go to musical memories from childhood, adolescence, and young adulthood. That's where your strength is. That's where the power is, because that's where the memories are strongest. Those older memories, music memories. The other thing that's over there is they can hear the rhythm of a question, but they don't have a clue what you said. But they hear the rhythm. So they know you've asked them something, but they don't know what you said, and nobody likes to feel stupid. So what they do is they respond as though they understand what you just said. Huh? Yeah? Yeah? Oh, hey, okay. Come on. Yeah. Come on. No, come on. Yeah. No, that'd be fine. Yeah. Okay? Okay? Yeah, well, that'd be fine. Come on, here. Come on. Yeah. No. Okay, now. Ready? Okay, now. Hurry. Okay?
Okay.
Okay, you ready?
Yeah.
You ready?
Okay, right.
Yeah.
Whoa.
Wait. Now, what happened here?
Hot in here.
Yes, yeah. They always get real hot about this for time. Now, here's what happened. Human beings really have 5 ways to get information from the world around them. All of us do. What we see, get your hand out. This is your cheat sheet, by the way. I love it because it travels with you. Start with your thumb. What you see, what you hear, what you feel, what you smell, and what you taste. See, hear, feel, smell, taste. Okay? These 2 are nice and important, but let's focus on these 3 to start with, because this is how we typically communicate with each other. We see things, we hear things, and we feel things. Now, when he was having trouble understanding and comprehending, he knew I was asking a question, didn't you?
Yes.
Yeah, you knew I was asking you to do something.
Rhythm.
Right,
Yes.
you got that rhythm. So what I did to get him to agree is I gave him visual cues about the right answer. What's the right answer? Yes, and because he got my visual cue, people with dementia always can pick up on visual better than they can pick up on content verbal. And they figure you're asking a question, so they're going, oh, okay, yeah, because they don't want to get caught. Who likes to feel stupid? So what they do is they go, oh, okay, got it. They didn't get it, but they're following along. So what I said to you, when you were right there, I said, now it's time for your shower, okay?
Okay.
And you said?
Okay.
Okay. And then now notice the really good visual cue I gave. Come with me. And because I was being friendly and smiling and everything, he thought, oh, okay, all right, that's fine. And he got up. Now, as we were walking up here, I said, now you understand I'm going to take all your clothes off, right?
Yeah. Well, I didn't get that.
Yes, you did, too. You said you did because you nodded your head, yes. And then we got up here. And I confirmed. Now, we're ready. You ready for a shower?
Yeah.
Yeah. Okay, now I'm going to take your clothes off, okay? Yeah. I'm going to start with your belt, all right? And then I said, are you ready?
Yes, yeah, I said, okay.
And he said yes. And then I started. Now, notice he did it again. This is not about having dementia. This is about being human. All of a sudden, out of the blue, what he thought was going to be the case, now all of a sudden I'm touching him. But it didn't match up with what I showed him and what I said to him. It came out of nowhere. And that's how he reacted. Now, what if instead I said, hey, how are you doing?
Fine.
Well, you're good. Well, you look good. Yeah. Hey, listen, time to wash up.
Yeah.
Okay?
All right.
All right. Let's start with your shirt. Right here. You do it. Mhm.
Okay.
Now, how was that different? They all matched up and they came together. Who actually put their hands on him? I did. Oh, but you missed it.
Oh. Okay.
I'm about to do an intimate thing, so I want to have physical connection. But I want it to be a friendly, familiar physical connection. Instead of out of the blue, somebody goes for the gusto. It's like, whoa, where is that? If he will not allow me to hold his hand and stay here, is he going to let me take his clothes off? Duh. And when I'm here and I signal him that we want to do this and I move his hand toward his shirt, if he has capability at all, yeah. He feels a lot more comfortable with he taking his own clothes off than me going for it. And notice I went for this rather than that. Why? This is a little less intrusive. This is like something that's not as scary as getting... How many of you would voluntarily strip your private parts down in front of somebody else? Yeah, I know, and we have another problem with you. I mean, and that's the problem. If people are okay with it, well, we've got issues with that too, because they tend to do it in places they shouldn't, you know. So this is where we do that. Now, we're going to talk about how do you help as the disease progresses. And what we will do, if he loses the ability to figure out how to do this, I become the fingers, but he is still there. And so we're going to do a little more of that later today. But I wanted to help you. When we talk about these symptoms, it's easy to not realize how what we're doing is having such a huge impact on what they're doing. Okay? All right. So we have just a few seconds before we take our break. And somebody moved my thing. Who took it? Well, I seriously wish you wouldn't take and move my stuff. Well, okay, it's all right, but next time ask. Now, y'all are learning an important lesson, which is, who laid that there? Me. But because if I have short-term immediate recall problems and I can't hang on to it, is it going to be worth it to point out that it was me who laid it there? Because what's going to happen if I think you're pointing out all the errors that I make? I'm not going to like you. And either that or my God, what's wrong with me? I can't keep up with anything. I'm losing it. I wish I could just die. Neither of those situations is a way we need or want to go when somebody has this condition. So what we need to do is basically say, I'm sorry, I don't know how it got there. I apologize. I might have done something with it. You didn't. You might have, but you didn't. It's all in how you say what you say. Yes, sir.
Is this why, as you get older, at least I get older, it's almost anal routine where I lay out things, I know exactly where they are, and if they're not there, then I don't know where they are.
We operate by habit as we get older. We use habits to get us through the day, and so what many of us do who are very visually oriented, we want to make sure that we know where everything is, because we don't like it when we can't keep up with stuff, and having it in certain places. Now, imagine that, however, I get worried because there are people in this house that take and move my stuff. And I know I can't, they'll take things. They've taken things out of here. I better put this someplace safe. And I put it in a safe place. Now, with normal thinking, I would look at where I normally keep it and go, okay, Teepa, where'd you put it? Son of a gun. I know you were I was thinking that somebody might move it, so I moved it and put it. I'm still capable of that because I have immediate recall. And I may not be able to think of where is it I put it without retracing my steps, because I've got to use visual, and I'll talk myself through it, because the talking out loud helps me remember stuff. And then I actually trace my pathways around. Now, let's see, I was here, and then I went over. Oh, there it is. That's what normal is. Early signs of this disease, no immediate recall. That woman who comes in here took that. And this is where it gets really tricky. My brain fills in the blank spots and hooks up. Remember how we have this going on? Put your two hands out. This is I took it and put it away. This is... She carried her pocketbook out to the car yesterday, and I saw her. My purse is missing. I saw her pick it up and carry it out, and she took it out of the house yesterday. I saw her take it. I am absolutely certain of that. I know I saw her. It's called confabulation. You can see it very early in the disease process. They become accusatory. What do we call it? Paranoid and lying. It's called confabulation. Their brain makes up stories to hook things together, and they don't not doing it deliberately. Their brain is actually tricking them. Because
appropriate response?
The pocketbook is missing, and I am so sorry that happened. Let me see what I can do to work that out. I am so sorry. You know what, though? before we call the police on her, can I take a quick look around? I'd hate to make a mistake and accuse her of something. And I know you're sure of that, but I would feel more, will you let me look just to be sure? Now, here's what you have to do when you find it. You cannot go, see, Mom, I told you. No accusing the person with dementia of lying. You got to let that go. And the hard part is letting it go. Because when you told a story when you were young, what did your mom do when she found out you told a lie? You had to not only, you got whipped, but you also had to go tell that person you were sorry for saying something that wasn't true. And that's what you want to have back, and it's not going to happen. Okay? Now, the last piece of this that I want to do before we take our break is there was a third thing in that temporal area. We had automatic social speech and everything with rhythm that we spent some time on. But the third thing, expletives. Swear words, sex talk, racial slur, ugly words. Preserved and stored over in a preserved chunk of brain. So swear words, all the swear words you put them over in this special category. You don't have them in your use every day category. You have in the hold for special circumstances category. And you learned that when your mom, the first time you came home and you said, hey, Mom, shit. And your mom went, what? And you went, shit. She taught you very quickly, that goes over in that category. You do not use that. And you went, oh, man, what a word. And you started building your vocabulary. Sex talk is over there. Sex words. We don't say sex words out in common publics. I don't know what this next generation is going to do, but, for us, that is not how we do it. And the other one is racial slur. Ugly things about other culture groups or other racial groups. We put them over there in the do not use in public kind of category. And the last one is ugly words. You idiot. Shut up. You don't know what the hell you're talking about. You imbecile. Okay? Think of how many ugly words, fat. Those words, they're over there and do not use. Don't use when you're in being nice. Now, when you're really stressed out, y'all will use them. Most of them. But not when there's a little kid around. Most of you. So what happens when dementia hits? I lose my ability to use the words I always would have used. Well, I really don't care for that. Thank you very much. This tastes like shit. To the waitress. Okay? I never even got anything to eat. Liar. Okay? That's what you're seeing. And you're seeing it not because of me, but because of the disease. Hands to the top, real quick. Before you go, you've got to go pee now that I've talked about it. But hands, and some of you, this is not a good place to have your hands because it's stretching your bladder and that's making it real hard, but hang on there. Index finger, back here, sensation. You have a map of your entire body up there on your brain. Little finger, movement. You control all the movement of your body from your brain. All your muscles are controlled from up here, and everything that happens is picked up here, no matter where it happens. Happens somewhere down there, but your brain is what tells you where it happened and what's going on down there. So as the disease progresses and that strip gets destroyed, I'm less aware of some parts of my body, but hyper aware of others. The parts I'm most aware of is where I have the most sensory end organs to start with. So the number one part of my body I'm still aware of, lips, tongue, and mouth. Second part of my body I'm most aware of, palms of my hands and my fingertips, particularly these three. These have a lot more input than the others. Soles of my feet. I need lots of input from the soles of my feet, or I don't know where I am and what I'm doing, and I can't lean over like this and not fall because that's all sensory controlled. Whether I've put pressure on the front of my foot, do I have enough weight shift? Have I shifted my hip? Can I pick that up without falling over? That's 1, 2, 3. Lips, tongue, mouth, palms of hands and fingertips, soles of feet. And the last one, genitalia. A lot of sensation right down here. So you're going to get one of two things. Sensory need, sensory tolerance. Sensory need, if I need stuff, I'm putting stuff in my mouth, messing with my hands, getting it down. If I have low sensory need, if I have high sensory need, having a great time. Your goal, you want me to stop. You need to think about meeting my sensory needs if you want me to stop. And that doesn't mean masturbation. What it means is you got 4 zones. I'm only using 2. The answer is not, hey, Teepa, how about bingo? Because you know what? I already got bingo going on right here. What you need to be thinking about is, don't sit under the apple tree with anyone else but me. Anyone else but me. No, no. Because what am I doing? Sensation in the hand, sensation in the mouth, sensation in the feet. Singing and dancing. You also want to think about getting people clean. So, hand sanitizer. Hey, how are you? You look great. Much better than, oh my God, ugh, gross. Okay. But on the other side, sensory tolerance. What can I put up with? So what kind of care problems are we going to come up with as this becomes prominent? That part of the brain is being attacked. Mouth care, dentures, keeping them in, using them. Whether or not I have problems about shaving, eating, pills, all that. Makeup, not so much fun anymore. Fingers, nails, touching, messing, doing things with my hands. Soles of my feet, I won't wear my shoes. Don't like that. Don't like certain surfaces. It's cold, it's cold, it's cold. Ow, it's hot. You're hurting me. Trimming my nails, keeping my feet nice. And genitalia. Continence episodes, incontinence episodes, having to go to the bathroom. Ow, ow, I don't like that, it hurts. Having a bowel movement now can actually hurt. It's uncomfortable, I don't like it, so I don't like to sit down and do it because it's not nice. And so I go hide and try to get, I might hit you when you try to help. Not because you're doing anything, but because my own body's tricking me. Okay? So, last part of your brain, hand to the back of your head. Back here, vision. When we come back later on, we'll talk more about that. But everything you see gets processed in your brain, and that changes over time as well. What we're looking at here is not the standard Alzheimer's pictures that most of you see. These are PET scans. This is the latest technology that's available. And what it allows us to look at is not the structure of the brain, which is what we looked at on the autopsy, but what we're looking at here is the chemistry of your brain, how your brain actually is working. And red indicates a high level of activity, yellow some activity, and the dark blue areas that you see are actually the ventricles in your brain or where there's fluid in your brain. And you want fluid in your brain. That's where the cerebrospinal fluid is that cleans your brain. You need that. You have those areas in your brain. Now, what we have are two pictures of a normal brain. So these are different depth pictures. And we're looking at a brain. This is a living human being lying in a machine thinking. We've asked him to think. And these red areas indicate lots of activity. Front, back of your brain, left side, right side of your brain. Two pictures of normal. These are the same areas of the brain with early Alzheimer's. And this is so early that if we actually did an MRI or a typical CAT scan, we wouldn't be able to see enough shrinkage to say for sure that you have dementia. We know there was some, but we couldn't say for sure. But look at the changes in the chemistry. Okay, and the big areas you see, learning and memory center, right through here. Left side of the brain, language, fine motor, high coordination. Driving in a thunderstorm in downtown Sarasota, looking for a road you've never been on with two people in the car and the radio on. What's going to happen? Problems. Because you or I would pull it together and be able to coordinate and organize what do we need to do. Turn off the radio, turn on the windshield wipers, tell people to be quiet, look for the road with me, turn the lights on. That organizational skill is coming from where? The front, and then I have to use my fine motor skills to do that. So what might happen? I think I'm turning the radio off when I actually am turning it up. I think I'm turning on the windshield wipers, but in that moment, I actually am not doing that. I'm turning on the radio. And then I'm, shut up, I'm trying to find, or I keep driving like nothing's happening. I can't find those things because in that moment, I'm panicky. Because the front of my brain and the left side, which is right hand function, left side of your brain controls the right side of your body. And look at how many controls are over there on the right side that I'm supposed to be doing something. And then I have to look in the mirror, look in the front, look to the side to make choices and decisions. And all of a sudden, I'm coming apart. And so I either slow down a whole bunch or keep going like crazy or jam on the brake, do something really stupid. And then I'm all upset. But I blame it on the people in the car, the this, the that, because I don't realize it's me. Late disease. Whoa. This is what that's going to, notice the red spots. Sensory motor. Vision. What I see is what I get into. Well, hey. Where did you come from? Oh, you got it there. And you better put it down. You got to get that and take it out. Oh my, look at that. You did it. You put it in here. And this is where you're like finding things in places torn up, shredded, messed with, and you're like, oh my God, what was she doing? Why did he do that? I'm sometimes going around now, up till now, everyone in this room would have described that as an agitated, aggressive person. But I have high sensory need in my hands, I have high sensory need in my mouth, and I'm looking for something to squeeze. And what I don't realize, it's a person. I mean, I didn't mean to hurt anybody. I was just squeezing on something. I like to squeeze things. I like to mess with stuff. And this is where I will do things, and you think I'm doing it on purpose, but it's... yeah, you got that there, and you got it. And then you get it and you put it up in there. And I stick stuff places. Lord knows I stick stuff. I mean, I have got stuff in my pockets, in my underwear. I'll get in the trash cans and I'll pull stuff out and I'll put gloves back on that somebody's had on. And I might do mean things, but it's not really. It's just sensation. I'm just liking to mess with stuff. But when you try to help me, ow, ow, no, that's enough. Because what you do to me is very different than what I do to you. Because it's a different sensation. It's a doing to versus being done to sensation. So these are people who may very well get into stuff. But let's look at the differences in vision. Is there a different amount of visual processing going on there? Yeah, let me show you a couple things that you really want to have your heads around that make a difference as the disease progresses. Take your hands, go high-low, look straight ahead, wiggle your fingers. Youngest people in this group can have their fingers way out, way down, and still be able to see them out the edge of their vision, even though they're looking straight ahead. We older people have to bring them in a little bit. Whoa, yeah, right about there. And not only top-bottom, it's also side to side. This is called peripheral awareness. As we age, our brain processing of vision slows down. We are not as fast as we used to be able to be. So what our brains say is, you know the most important part of vision? The middle. So you know what I'm not going to pay attention to as much? The edge. So what they develop is called peripheral inattention. By age 75, normal visual field. Normal 75-year-old. Nobody with dementia, just normal. About 45 degrees off center. This is the visual world of a normal 75-year-old. Now, notice when you're 75, suddenly you have to watch those little step-offs because suddenly you're like, oh shit, what happened? You didn't notice them because they were below your peripheral field, especially when you're carrying a load of laundry or you're doing something where you were distracted. When you're pulling up to a traffic intersection, you look left, right, you look left, you pull out, oh crap, where did he come from? Because you thought you looked further than you looked. Because you don't know what you don't know. You don't realize this is happening. You crack your head when you come up from under the table. I mean, all kinds of things happen to us. And all of a sudden we're going, crap, what's going on here? We're getting old. You're slowing down. Normal. Dementia. By mid-dementia, which is when, what did I say typically happens? The diagnosis happens. Take your hands, put them about 12 inches apart, and make a circle. This is the world of somebody in mid-stage dementia. That's it, guys. That's all they can pay attention to. So it's between those two parts. Now, here's the best way for you to get your head around this. If you have glasses, you might want to just put them out of the way. Put on binoculars. Now, stand up a second and walk just a little bit. Walk and notice how your gait has changed all of a sudden. Notice where your gaze tends to be. Notice what your speed has changed. Notice how your step length has changed. Now, sit back down. Now imagine, combine that with problems with immediate recall. So you laid something down, and you can't figure out, and you can't scan. It's called, you lose organized scanning because you can't figure out where you already looked before you look again. And so your glasses are laying right there, and you can't find them. You literally cannot find them. So I lay things out and I can't see them. And of course you come along and say, well, they're right here, Mom. Well, who put them there? Well, you did. I did not. I put them over where I always keep them. But I can't keep up with it. Now here's the second piece. Take your hands, put them around your eyes, scoot up to the table, and put something right in front of you on the table. Just move it right back here, like right at the bottom. Now look at the table and realize you're not going to see that. So if I serve you a plate, you're going to reach across the table and get somebody else's food, thinking you don't have your food. And the reason you're doing that is you lose your peripheral field down here. It's not just out here on the edges, it's top and bottom and sides. It also means if I come up from behind you, good morning. It comes out of nowhere. And people get startled and they get scared and they think somebody's jumping them. And now their energy level's up, but they're just nervous. And what you don't realize is you're the one that's doing it. You come up to people, you don't give them a visual cue and a verbal cue, you just touch them. Here we go again. Okay? And what you have to realize is their field is a lot smaller than you think it is. Okay? Now, also realize, put on your binoculars and look down, tell me if you need to change your shirt. So how many times do we walk up to people and go, oh my God, Daddy? I mean, how many days, look at this, you've spilled stuff all down the front of you. They don't even know they've done it. And so we point out all these errors like they're an idiot. And in fact, what we're looking at is visual processing problems. Okay? Now, if you have a visual disease on top of this, like macular degeneration, where you lose your center field, all you have is the peripheral, but you can't use it. And so what happens is I actually have to look straight ahead in order to see this man. But my ability to understand where he is in relationship to me is a little iffy. So if he suddenly touches me, it might still startle me, even though I know he's there, because I can't put the pieces together, because usually it's my center field that lets me know where things are and what to do, that detailed work. So of the worst combos, one of the worst combos to have is macular degeneration and Alzheimer's. Horrible combo to have. Horrible. And the only thing that makes it worse, being hard of hearing. Now, the skills that I talked about earlier can really help you out, because if you're doing hand-under-hand guidance, it helps the person figure things out. But if you're just running your mouth or you're pointing, you're saying it's right there, not particularly helpful. Okay? Now, as the disease progresses, it doesn't stop there. That's mid-disease, somewhere between these two pictures. Late disease. What happens now is another phenomenon. Normally what you get when you look is that you have an image coming in through each eye. Each image comes into your brain, gets processed, they get flipped upside down, and one gets laid on top of the other so that you create a three-dimensional image of the world inside your brain. You see in 3D. So put two fingers up and look. And if you have normal vision, which most of us do not, but if you have normal vision, you can actually tell which of your fingers is in front of the other one. Close one eye. Now close the other eye. Now close one eye. Now close the other eye. Those fingers are moving. Really weird, huh? What happens in late dementia? Your brain goes, man, I can't handle two images at once. This is too confusing. I can't make them line up anymore. So what it decides to do almost always is shut down processing in one eye. It ignores one eye, and you develop monocular vision. Because having double vision is so distressing. When you can't make it line up, you feel sick. And so what your brain does is, you know what? Shut it down. Just ignore it. So they have monocular vision. So put a monocle around one eye. Now, here's what I want you to do. Really concentrate on looking at your index finger. Focus in on it. Keep looking at it while you reach out. Keep looking at it and try to judge the distance to an object as you look at your finger. Try to reach out and figure out when you're going to touch something. Now, scoot your chair back from the table, and let me show you a real yucky one. Okay? Put on your monocle, look at your finger. Track the finger to the floor. You have no idea when your finger's going to touch the floor. You thought for sure you would be touching the floor. Now, this is what this means in late disease. My sensation is not coming in as well as it should. I don't have as much advance notice. I think I can reach that table to balance myself. I have no idea it's that far away. So I start to reach for it. Now, what would you or I be able to do? We'd pull our sensory system, motor response, and go, oh, okay, hang on, didn't have it. Hang on, let me fix it. By the time, I'm down. So we're going to, late in the disease, we're going to see fall, 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 fall. And it's not anybody doing something really wrong. It's the disease really causing incredible amounts of damage in such important parts of the brain. But can we make a difference? Yes. This is where we have to get off the routine bus, however. What happens after somebody has a hip fracture and they recover? What's the most common piece of equipment we see them get? A walker. If I've never used a walker before in my life, I'm 82, I've never had a walker. I've walked my own self everywhere I've been for 82 damn years. I don't need a walker. What's this about? Where did this thing come from? Honey, move this thing out of the way. Or I just get up and ignore it. Because that's a new piece of information, and I'm operating on old knowledge. Now, let me just check in this room. How many people in this room can ride a bicycle? Raise your hand if you think, if I put you out in the parking lot, gave you a regular bike, not a 10-speed or anything, just a regular old bicycle, how many of you think you could get on there and ride it around the parking lot? Keep your hands up. How many of you actually ridden a bicycle in the last year? Last 6 months? Last week? Why'd y'all lie and say you could ride a bicycle? What are you basing that on? Your old information. So people with dementia just do the same thing. The problem is they don't have any idea that this has happened to them. And so they think they can do things they can't. They don't realize they need that walker. So we need to quit acting like a walker's an answer. It's not. It's not. What we need to do is build handrails through the home that take people where they need to go. We need to place furniture, solid, stable furniture, within a walking path so that they have a walking path, but they're going to be able to put their hand on something that's stable and not mobile all along. Instead of, here's my walker, there's my dresser, which one do you think I'm going to reach for? The dresser, the thing I know, and so I'm going to reach out because, and I'm going to go down. So we actually need to reconstruct our environments to recognize the changes that are going on. We can't expect folks to get it. And just because I used my walker this morning will not mean I'm going to use it this afternoon. And this is where people get tricked. You say, well, where's your walker? What walker? And then 5 minutes later, honey, I need my walker. And it tricks you into thinking, okay, I know I need my walker. It's here, it's gone. It's here, it's gone. It's here, it's gone. The other thing that's very consistent at the late stage of this disease, wake-sleep cycle disturbance. Wake-sleep cycle disturbance. I don't sleep like I used to sleep. Here's how y'all sleep. You go to sleep. You go down, you drop down into REM sleep. REM, deep, refreshing sleep. You need about 5 hours of good REM sleep a night to function. You sleep more, but you only need 5 hours of good REM sleep to do this. You drop down into REM, you come back up, but not all the way, just part way, and then you drop back down and you come back up, you drop back down and come back. That's you. Late stage dementia. I'm here and I start to go to sleep. I can't get into REM sleep, so I bounce back up. Wake up! I got to get to work. It's 2 in the morning. What will you say? It's 2 in the morning, Mom. Go back to bed. No, I've got to get going. So you hope that you lock the door and that I'll behave. And then you hear, and you're like, oh my God, what's she gotten into now? And I'm doing all kinds of things in the house at 2 in the morning because I see things and think I'm supposed to do them. But because of all the impairment, I'm doing them wrong, making mistakes, making a mess, tearing things up, getting myself in trouble, tripping, falling. So you can't sleep solid. So what's happening to your REM sleep? You're not. You're trying to get in, you're bouncing back. Oh my God, what is she doing now? I have actually seen family members sleep in front of doorways in hopes that I will trip over them on the way out. Okay? What this means is you wear out because I can't get into that deep sleep. I catnap during the day. It's the best I can do. Putting me with drugs does not make me go into REM sleep. What you're doing is sort of trying to get me down, and you can knock me out, but you won't. I don't do REM sleep. I don't do that deep, refreshing sleep. So I'm still going to catnap. I need to do some of that. You don't want me sleeping all day, but catnapping is very normal for me in these late stages. I come and I go. I drift off and I come back. We need to acknowledge, here's what's going to happen. If I eat breakfast, I need to sleep for a little bit. After I eat breakfast, I should be allowed to sleep for a little bit. Put on some quiet music, put on something nice, put on wind chimes, put on whatever I enjoy, and let me sleep for a little bit. Because where's all the blood in my system right now? Digesting food. Do you want me to digest my food? Yeah. And you want me to rest. You need me to rest. You need to kick me back in a recliner. Get my feet up. Get me elevated. Because the other thing that's failing, my circulation system. Not working so well. So I pull down there. I start to get edema down in my legs and my feet. I don't get good venous return. Those veins are just not listening. That's all coming from the central. It's not, the baroreceptors are not responding. I drop my pressure when I go to stand up. Okay? So you actually need to go ahead and let me lay there, digest my food for a little bit, and then turn the music into something a little more lively. A little more lively, a little more lively. Until what are we going to do? Get up and start moving. Get up and start doing. Get up and start rocking and walking and doing things. We need to build a schedule that matches my skill set. That means you're going to need help. It's not a Lone Ranger disease. You're going to need other people stepping up and helping out. And for some folks in the later disease, the time you really need somebody might be nights, so that you can get some rest during the days. There will also come a time, this wakefulness is almost always one reason people can't continue to do the home caregiving. It will wear you out. Even with caregivers, it wears caregivers out, paid caregivers. It's exhausting to do this all the time. Human beings are just not made that way without dementia. What I want to do is not get weighed down in looking at the different dementias right now, because they're so complex. What you need to know is there are different dementias. Each dementia should be managed specifically as that type of dementia. And I can also tell you that we can be about 95% accurate on the type of dementia we're looking at if we do a good workup. The bad news, only about 20% of all people get a good workup. They get a quick 20-minute office visit. Well, your mom probably has dementia, and I suspect it's Alzheimer's. You know, she's 82. We'll start her on some Aricept, Exelon, Arazidine, add a little Namenda, and you keep track. If it gets to where you can't manage it anymore, you let me know, and we'll start looking for places. If the behavior gets real bad, let me know. We'll have to put her on something for that. That is not uncommon at all to have that happen. You cannot do a good diagnosis of dementia in an office visit. You certainly can't do it over the phone, and you can't do it just based on 1 or 2 episodes of behavior. It really does require a fairly complete workup. Now, not everything is straight out one or the other. And the problem with a lot of docs, they aren't even looking for what could it be, and they don't look for mixed picture or atypical or other dementia. And there's lots of things that it might be. We need to hold them accountable. If you went to the doctor and you said, you know, you're 45, you're losing weight, even though you're not trying. You've got sore in your mouth that you can't seem to heal. You feel crappy all the time. You have no energy. You just can't, and you catch everything that comes around. And you're just feeling miserable pretty much all the time. And the doctor said, well, you know, I suspect it's probably HIV. How about we start you on some AIDS medication, see how that goes? How many of you are calling the board on that person and saying, excuse me, they didn't even do a workup? I mean, he just assumed it was HIV. I mean, I don't understand how he could assume it was HIV. Because could it be a bunch of other stuff? Would you expect a good workup? then why do we let people get away with it when somebody turns 80? Because we do. We let people basically do nothing but a brief screen and move forward as though there's no chance it was anything else. And it's not fair and it's not right. We know that there's lots of possibilities. So if you're noticing changes, what should you do? You need to get it assessed. But before you get it assessed, when you first see any of the little possible changes we've talked about, get an elder law attorney and work out your health care power of attorney and your financial power of attorney before you go further. If possible, you might even want to think about long-term care insurance if you're young enough and can afford it. But you want to look for a policy that covers dementia. Because once the diagnosis is made, things get rough. So y'all need to get seeing somebody before you even go see the doc to take care of other things. Because a health care power of attorney is going to enable you to continue to have conversations and advocate for the person even though they're struggling and don't think they need anybody to advocate for them. If you don't have any of that in place, you then want to go to a lawyer once they're diagnosed and they're showing symptoms. They're going to say, well, we're going to have to do guardianship. We can't do the power of attorney because they are no longer competent to make that choice. And it becomes a legal mess. And these guys, I'm sure, will talk more about that stuff. But one of the big problems is we wait too long. How many people in this room actually have a health care power of attorney for yourself? How many of you have a financial power of attorney worked out for yourself? In other words, your will and your advance directives and who's going to be making decisions. If you don't, you have no business telling the person you care about they need to. Because we need to do ourselves first before we ask somebody else. And I've been much successful with folks if I say, I just went to a workshop and they were talking about how we should have our health care power of attorney worked out, so I'm going to go do it. Mom, would you like to go with me? Maybe you could do whoever you want too. And we do it as a shared activity, not a you should activity. And it's a lot more successful. But we want to work those things out. You want to work out financial stuff before you get in the middle of this mess, if at all possible. Because once you're in the middle of it, it can turn ugly fast. And let me just say, 4 out of 5 families, so do this, 4 out of 5 will fall apart and not like each other before this is all over. Only 1 out of 5 pulls together and forms a team. That's national statistics. So if you are one of the 4 out of 5, don't feel bad. You're in with the most. If you're 1 out of 5, feel blessed because you actually are a minority. But our job as healthcare providers needs to get more families on the bus and being successful versus so many of them failing and falling apart and having relationship issues that never get resolved. And it's tragic. It's truly tragic when it happens, but it does happen, and it happens with great regularity. So why do you want a diagnosis? I've already told you can't fix this. Well, you want it because you need to plan. You need to figure out what's the prognosis, what's the progression pattern going to look like, how long might this take, and each dementia is different. There are some dementias that I can tell you, you'll be lucky if you last 3 to 5 years. There are other dementias that it's average 3 to 30. Try to plan for that, baby. And there are yet others that are about 8 to 12 on average. There's some that are 7 to 9. What we're looking at is average, but if I sort of have in my head what am I looking at least I've got it. And I also know what's going to go first, what's going to go second, what am I looking at third, so that as I'm figuring these things out, I know what I need to do. If you have Lewy body, you got to do environmental mods very early on, and you're going to have to deal with some of the hallucinations, very likely, because they have lots of hallucinations in the evening and at night. Paranoid thinking, delusional thinking. Okay. We also want to have plans because we've got to work out how these finances are going to flow, because it's amazing how expensive this is. Dementia is probably the 3rd most expensive disease to treat and manage for its duration, and it is bottom of the barrel for government public funding. So almost everything is donated, volunteered, or private pay. And it's getting worse, not better. And it's devastating. I mean, we're talking huge sums of money being invested in this. And finally, we also need to make future plans in regard to health care. Because by mid-disease, you need to be deciding, well, we're seeing some symptoms, maybe they have a cancer. This is when you start asking the question by the later stages, What would we do if we did a study and found out it was cancer? What would we do differently? And if the answer is, well, nothing. I mean, we're not going to do surgery. I mean, I don't want to put her through that because the outcome is really not real different. I mean, I'm not going to do that. She won't be able to tolerate radiation. Because what do you have to do to get radiation? Lay real still. Stay in the same position for a long period of time in an uncomfortable position in a closed up place with stuff and not. So if we're not going to be able to do anything about it, why do we go to all the hassle of putting her through all that versus manage the symptoms? So the kind of care we're going to be delivering over the course of her life is going to change depending on where she is in the disease and what else is going on for her. We need to get smarter about making better decisions. When are we going to move to restorative? When are we going to use to maintenance? When are we going to move to palliative care? Not hospice care, palliative care. And finally, when do we go to hospice? Palliative care is comfort care. What I'm going to tell you in dementia, we need to move there faster, sooner, and get there a lot more together as a team rather than arguing about it. Because comfort care is care. It's just different. It's not curative. We're not going to try to fix things. Okay? We also want to try to be in control of some things. And if I've done an evaluation, I know what I'm looking at, then I have a better sense of control over what's going on versus it's just happening and I'm along on the ride, but I'm not driving the bus. It's exhausting to not know what's going to happen next. When's the next rest stop? When are we going to get off? Is there going to be a break? When can I have a break? Can I have a break? Can I take it now? Should I wait? What do I need to do? I don't know because I don't even know where I'm going. I don't even know I'm on a journey half the time to start with. And finally, medications might actually be very different for the different dementias. So you want a good evaluation to know whether, when they say, how about Haldol, we'll say, no. I think we have Lewy body. I think that's a really bad idea because I am really concerned about Lewy body. Let's look at other alternatives first. If we have somebody who is giving us the opposite reaction on Ativan, normally Ativan calms people down, but for me now I'm throwing the chair. Heads up, double the dose is probably not the answer. But knowing what kind of dementia it is makes a difference. So what should happen when you go to the doc? Well, here's what should. If you are concerned but younger than 65, there should be a screening that goes on for your thinking. And the screening should simply involve something as simple as animal fluency. Orientation and 3-item recall is something else. Orientation is what day is it, what day of the week, what month, what season, what year, that kind of orientation. Also, where are we and what's going on here? So I'm asking for very basic questions. And then a 3-item recall is ball flag 22. What were the 3 items? Give them back to me. And the third is clock drawing. Okay, where I ask you to draw a clock, put numbers in the face of a clock, and then put a time on the clock, a specific time on the clock. And by doing those 3 little things, which on average will take approximately 3 minutes, I can find out whether you're changing over time. If I do it, establish a baseline, look back the next time you come, look back the next time you come, look back the next time you come, then I can say to you, you know what? You're right, something is going on. Because you were doing about 27 animals and now you're down to 22. And we shouldn't see that kind of change. Something's up. Let's take a look. I think we need a full-blown eval. The MMSE is short, not particularly helpful anymore. It's not the best one to use for, it's called the mini mental state exam. What's the day, what's the date, what's the day of the week, what's the month, what's the season, what's the year, what's the name of this place, what town, what city, what state, what county. Also, then I ask you, ball flag 22, what are those 3 words? Take 100 minus 7, minus 7, minus 7, minus 7, minus 7, minus 7, or you can spell the word world backwards, and I ask you, what's this and what's that, and I ask you to do what it says on this piece of paper, and the paper says, close your eyes. Take this paper, fold it in half, put it on the floor, draw 2 intersecting pentagrams, and write a sentence. And say this, no ifs, ands, or buts. Okay. It was originally designed over 30 years ago as a screen to determine whether you might have dementia, depression, or delirium. That was how it was originally designed. It's currently being used as an assessment tool to determine whether or not you have Alzheimer's. It is amazing to me that we went from this to that, and there has been no change. And it's like, whoa, wait a minute. What we are finding is people who are bright can pass that and have Alzheimer's. People who are not so bright fail it, and yet they don't have Alzheimer's. They're just not real bright. I mean, and unfortunately, it doesn't discriminate very well. The newest tool on the market is called SLUMS, and it's actually a public domain, St. Louis University mental screen. It minimizes the amount of orientation questions, but it asks you to remember 5 items. It includes animal fluency. It asks you to do number reversals, but instead of doing serial 7s, what it says is, I'm going to give you some numbers. 4, 8, you would say 8, 4. 3, 2, 7, 7, 3, 2. So I'm asking you to do some manipulation, right side brain, left side brain. I tell you a story, you have to remember and answer 4 questions about that story. And it has you look at shapes and identify a triangle and which one's largest. So it's much finer tuned, and it also separates out college or high school, not a high school. And it looks at normal, MCI kind of things, and early dementia stuff. So it discriminates better.
St. Louis University
Mental screen. And you'll see it online. It's available online. It's great. And then open the discussion about, tell me more about this problem you feel like you're having. The doctor should ask you, tell me more about this. What's happening? When do you notice it? What are the things that bring it up? Because what we have to do is start the discussion. So let me have you do the animal fluency real quick, just so you get a feel for it. Pick a partner. Pick somebody to work with. Doesn't matter. Find a partner. Okay. Now decide who's going to talk and who's going to listen. Who doesn't have a partner? You don't. This lady, oh, okay. Yeah, you can be his partner. Let's see back here. Okay, you've got a partner back here. Okay, good. All right, here we go. Okay, who's going to talk? Raise your hand. Okay, here's your job. You're going to name as many animals as you can think of. Just name as many animals as you can think of. I will say go. You will start naming animals. You will keep naming animals until I say stop. Okay, just keep naming as many as you can think. Any animal. If it's not a vegetable or a mineral, it's an animal. Okay, got it? Okay, you good? All right, now here's the other side of it. Who's listening? If you're a listener, here's your job. Keep track of how many different animals they name. So you just need to make tick marks or keep track of how many do they name. You don't need to write down what they name, but just how many they name. Okay? Now, here's the deal. Let me say this right up front. Regardless of your score today, it doesn't count. Okay? We'll talk about why in a minute. But okay, you ready? Get set, go.
Dogs, birds, rats, mice, giraffes, elephants, owls, cats, bees.
Okay, stop. Stop. Okay, jot down your number. All right, now what we're looking for, they're supposedly, quote unquote, national averages. Yeah, okay, so let me ask, how many of you, if you're younger than 65, the score that we're looking for, just on the animal fluency, not using it in the slums, is did you get at least 12? Oh, now I wanted to say to you, remember I told you it didn't count. Doesn't matter. All of a sudden you're going, yes, I'm okay. Now you think people aren't scared about loss of cognition? Now, do you also understand why it can't count? Because some of you all, there was a lot of background noise, and here's the two extremes. Somebody who heard somebody else say something, they go, oh, I can't use that because that would be cheating. But because you heard it, your brain can't seem to let go of it, and it's like, let go of that, I got to think of something else. On the other hand, the people who are really scared they weren't going to get enough, horse, cow, yeah, whatever that person said, you took it. I mean, you were just waiting for them. Yeah, sure, let them name another one, I'll take it. Okay? That's why we can't count it. Now, let me also say that everyone in this room did something along these lines. Okay, if you have normal cognition, and we'll find out in a second. What you did was you went dog, cat, bird, fish, rhinoceros, zebra, elephant. Okay, hang on. Wait a minute. I know more. Okay, hang on. Wait a minute. Oh, horse, cow, sheep, goat, turkey. Okay, wait a minute. Oh, tiger, lion, otter, walrus. Wait a minute. Hang on. No, shut up. Now, this is what you wanted to say to the person behind you that kept interrupting. Now, what happens is you get about 5 to 8 in a category, and then you got to go back to the file cabinet and find more. Find another category or something. That's because human beings can hold at most in working memory at any point in time 5 to 8 pieces of information. That's all you can hold. Once you get through the 5 to 8, you got to go back and start over, and you go to the long-term storage unit, pull it open, and look for it. But everybody in this room got about 5 or 8 and then started struggling a little bit and then had to go look for a new category, types of dogs, kinds of cats, things from the zoo, things. Now, some of you had another strategy. You did a twofer. You didn't do what I just did. You went antelope, bison, cat, dog, elephant, fox. You see, and what you're doing is a twofer because you used an organizer on top. So you did a two thing. Wow, pretty skilled, but it slowed you down a little bit, but it kept you on track because you came up with an alternate strategy. Now, once you get through the alphabet, you may either come back to A and have to, now what did I say last time? Whoa, much more complicated. People in the room, in general, did not go dog, cat, bird. Oh, jeez. Now, what's the one that's got a bushy tail? Shoot. Hang on. Wait a minute. I'll think of it. They run out and get hit by cars all the time. Oh, God. Gosh. I know this. Wait a minute. Let me think. They store those things in their cheeks all the time. In the winter, oh God, they're like rats with fluffy tails. I mean, they'll get in the house and they can tear out insulation like crazy. And what's happening is I am so invested in naming this one thing. What we do is I go off on a tangent. I cannot stick to what it was we were talking about. I can't do that because I've got to find the name of this thing. I get so wrapped up in finding it. Or, yeah, well, you do, absolutely. People with OCD do that. You also see it with early Alzheimer's. People will not be, it's called circumlocution. They talk all around the word. They can't find the word, but they can't give it up. They got to try to find it, and so they're working around it, and they can't let it go. And yet, if you were to say squirrel, they might say, shut up. Because they're so busy thinking that they can't even hear you, and all they hear you as is a distractor, and so you're trying to give it to them, and they can't even get it. The other extreme might be, why do you need to know? What is it you need to know? You're going to put me somewhere? Is that the deal? I know lots of animals. You want to know them, you say them. And you're like, whoa, man, what's this anger about? It's fear. It's fear. It is not anger. It's scared to death. I'm scared that something's wrong.
How much time did you give us?
1 minute. How many of you would have thought it was a lot longer? Yeah, and how many of you thought it was much shorter than that? Yeah, I mean, it tends to feel one way or the other depending on how much trouble you're having and how hard this is and how distracting the environment was. Some people give up. Some people keep going. But what this is I can establish your baseline and then compare you to you over time. This is a skill that will not change unless something's going wrong. Something has to have happened. Whatever you're able to do, you're still able to do. And it's accurate in that you have to go find it every time. You can't hang on to this stuff for 6 months, which after they do the mini-mental for a while, it's so important. They learn that they know what the questions are going to be because there's emotional connection to it. They know what they go through. It's so embarrassing not to be able to think of this shit. So what happens? I hang on to it. And so right before I go in there, now what's today? Because he's going to ask. What's the name of this place again? What floor am I on? Oh, yeah. I've actually seen demented people put the answers in their hand because they want to perform well for the authority figure. And they know this is important. Hell, I know what this means. You can put me someplace if I don't know how to do this stuff. And what happens, unfortunately, is the wrong thing. So these are the things that should happen. Now, notice the difference between if you're younger than 65 or older. It doesn't matter. We've got to quit having this break point of, if you're over 65, well, then we'll just do this. Okay? If the screen, and that was just a screen, indicates we have issues of concern, what we'd want to do is rule out the other 2 Ds, which were depression and delirium. And then we want to look at all their meds. The doctor should be saying, I want everything they take, everything, whether it's over the counter, whether it's a supplement, whether it's a vitamin. I want to see everything they're on. Everything. And I want to know how often they're taking it. There should be a complete workup and a follow-up. Or they should send you for a full neuropsychological evaluation. They should evaluate you completely and then follow up with you. They deserve that. People deserve to be talked to. Not, well, I don't know. I mean, we can start you on some Aricept. Would you like that? I'll call that into the pharmacy for you. So I literally work with people who are on Aricept who don't think they have dementia. They just think the doctor put them on Aricept. We find it in pocketbooks of people who got out of their car after running out of gas on a back road because they were thinking of going to the grocery store, got lost. And we find them dead in the woods. And the family didn't even know that the person was diagnosed. And they don't actually have it on their chart. They're just on Aricept. You don't get put on Aricept. You don't get put on those drugs right now in this country unless something's going on. But it doesn't mean you've heard the diagnosis. Okay? It is pretty scary. It should be scary. It shouldn't be happening, but it is happening. It is happening. We have two major situations when you're trying to get a workup or a diagnosis. Number one, the person's aware and cooperative. Or number two, they're not aware, they're not interested, or not willing. I don't need to go see the doctor. I don't see why I should go see that. I'm fine. I am fine. I'm not going there. These people are charlatans. All they want is your money anyway. Why do you think they might be doing that? Fear. Fear, anger, scared. They've had bad situations. They don't trust doctors. They are scared something's going on. They're afraid somebody's going to catch it. They're afraid life's going to change because, let's say, my grandma had it. Now I'm looking at me. I don't want to go get this done because what if it's true? All of a sudden people are going to be taking over doing things. I didn't like how that turned out. So this is a real life, these are reality checks. So what should happen, what should not? This is what should happen. There should be a complete physical, medical, psychological history taken about this person. Number two, there should be a good history taken from the person and from the family of the problem in separate interview rooms. You should never be asked to report on the person you care about in front of that person. Never. Because if you have to say some hard things and they are not able to hear those because they were not somebody who wanted to come in the first place, what you can get is, I will never take you with me to the doctor again. I cannot believe that you said that. You lied about me. You are not going to be my health care anything anymore. I'll tear the damn paper up. You think I won't? You are never coming in my house again. I'll call your sister. And all of a sudden, what you had worked out is not worked out anymore. Because at this point in time, do I still have the right to change my health care power of attorney if I can demonstrate to you that I am competent to do so? Told you, get her ass out of my house. I don't want her to have anything. Okay? And sure enough, because in that moment, what's my chemistry doing right now? Honey, I'm cooking with gas. I am so mad, I've got every chemical branch in my brain going, whoo-wee. And what happened was, you said what might be true, but because I was scared about this already, I couldn't hear you say it. You need to be real careful and real aware of where I am in the disease process versus where you are. We also got to be real careful about spouses. Because in general, a spouse will be the last to notice the changes. And the first to try to cover it up and preserve what is. Not because they mean to, but it's just their nature. That's their job as a spouse. You're a partner. You're in this together. And truly, when you live with somebody all the time, it was so gradual, you didn't even notice it. Everybody else is pointing it out to you. Professionals will almost always pick up on it first, then the family members, and then the spouse. The spouse is the last to get it. Or the spouse is the first to get it, but they don't realize they got it. Their whole behavior's changed. Everything about how they interact with the person's changed. And the family's noticing that and saying, Mom, why are you being so mean to Dad? You yell at him all the time. Well, he's just not even paying attention. He's gotten to where he doesn't listen. I think it's his hearing. It's not his hearing, it's his thinking. But I don't know that, and I don't even realize how much I've changed. I'm totally unaware of it. It's been so gradual. And sometimes the kid in town is the same way. They're around all the time. It's been so gradual, it's happened so just over time, you don't even notice it anymore. Somebody comes in from out of town, they spend a little time, they go, God, what is going on? Mom can't even cook anymore. You're doing 3/4 of it. No, I'm not. And what do we call that when I do that? Denial. It's not denial. I just don't get it. Forcing me to recognize it is not a healthy thing. Helping me to recognize it is. There's a big difference between forcing and helping. It's real important that we know that. We want a thorough physical exam, neurological and cardiac exam with good blood work done. That's what people deserve. You also want to look for a medication review. You should also see an imaging study of some sort. Here's the bad news. Medicare won't pay for it if it looks like normal Alzheimer's. What's the point? The only reason physicians do it now, and they typically will do the CAT scan or the MRI, they do that now to rule out tumors, to rule out strokes, to look for vascular. Over the next 5 years, this thing called a PET scan or a functional MRI is probably going to become common practice because you can see these diseases well before the structural changes get solid with the chemical pictures. It's possible. It's just not covered right now.
But older people, you know what it's like to stay in an MRI for 45 minutes.
I do, and so there's open MRIs, and that's why the PET scans are popular. The other thing that we may actually start seeing with great regularity is them pulling off spinal fluid and looking at the protein malformations in the spinal fluid. Because if you have Alzheimer's, there'll be a change in the how much beta-amyloid there is in the spinal fluid and the tau protein. If it's Parkinson's, we see synuclein protein in a certain pattern, and if it's Lewy body, we see it in another pattern. If it's a combination, we will see it. We can pull off spinal fluid and see all that at the very beginning of symptoms. And basically, pulling off spinal fluid is basically like doing an epidural. I mean, basically, it's like getting an epidural. How many of you ladies, back when you had children, had epidurals? How many went, oh my God, an epidural? No, you went, oh yeah, give me the epidural right now. And that's where we get in our mind, oh my God, epidural, oh how horrible. And in fact, it may be the simpler way to look for this stuff and help us know what's going on and what kind of dementia we got brewing. Yes?
Somebody's 95 with dementia. Would you put them through all?
If I already know what they have as dementia, no. If it's early though, and I don't know, yeah. What we're talking, if you're already in mid-stage or further, at this point, I can tell you after you're listing symptoms and asking you some questions, I can be over 95% accurate in about a 5-minute conversation with you about what kind of dementia you got going on. So no, I would not do that for somebody who has lots of symptoms already. But for somebody who's showing first signs, or we don't even know if it is dementia, this is what should be taking place. And unfortunately, that's not what people get. I mean, what we're talking now, you don't know this till it's mid-disease, and now it's past mid-disease, and now we're saying, well, is it dementia? It's like, well, yeah, it's dementia now, but, it would have been nice to know this 5 years ago when I was yelling at her, fussing at her, or telling her, why are you not taking your pills? Or she didn't take her pills right for 5 years, and so therefore we've got other issues going on now on top of her dementia. Okay? Yes, sir. It's a different process. One is a functional imaging thing, and the other one is this one is actually allowing us to look. It's a different kind of machine. It looks at, we put in a radiographic isomer, and so isotope, and we're actually able to look at the chemistry of your brain.
Do people that have pacemakers, are they allowed to have?
Yes, they can do a PET. They can't do an MRI. Correct, because there's no magnets involved in the PET scanning. Yes.
I was going to say, one of the things we found in our organization is people on antihypertensives who were put out in the halls and sat for a long period of time sitting up had a lot of dementia symptoms, but they actually didn't have dementia. They had physical complications because of their meds.
Exactly. I mean, and this is where, again, we need to do a better job, and we aren't doing a good job. And it's not fair. It's just not fair to folks. And here's the last two is neuropsychological testing, what works and what doesn't in the brain, because they can actually be a lot more accurate than some tests as to what we're experiencing working with folks. And finally, there should be follow-up in counseling. And the reason it needs to be follow-up, not in the original session, is they've done studies. And what they find out is once the individual and the family hear the words, well, I think it might be dementia, and I suspect Alzheimer's, or I think it's Lewy body, or I think what might be going on here is some form of dementia. When they've done the study, people hear nothing after those words come out. Their brain immediately goes into flight, fight, fright. Flight, I want a second opinion. I'm going to go get a second opinion. I don't think this person even knows what they're talking about. Come on, Mom, we've got to get home. Come on, we've got to get out of here. I don't have that. I don't think I have that. Fight. I knew it. I knew it. I told you. I told you there was something wrong with her. See? See what I'm saying? You're nutso, Mom. Okay, I'm angry. I'm mad. It's going to change everything. I don't like this. I'm angry. You idiot. You don't even know what you're talking about. I'm going to go see somebody who does. I don't have dementia. I know I don't have dementia. I'm angry or frightened. Oh my God. What does this mean? What's going to happen? What will happen? But when I'm in automatic meltdown, I can't process anything. There's no point in us talking any longer. What you need to do is let me recognize I'm grieving. I am grieving the loss of me. I am grieving the loss of my person. I'm in immediate grief mode. Oh my God. Oh my God. So what we want to do is give them a little bit of moments to heal, come back, and let's talk about what's going on. You can't do that in one session. It's not possible. People need to acknowledge what's happened, and they need to give them some time. Tell me what you think is happening. What's going on for you? Yeah.
But most people go to a general physician. And you had a form that slide.
Yep, sorry.
Medical, physical, psychological.
Yeah.
They don't have, other than that stupid little test.
Right.
They usually say.
Yes.
A psychological.
Nope. They don't even do a depression screen.
How is a patient to be able to say, well, I want you to do, who's going to do that component? Most patients and families
You want to ask
don't
for a
know.
referral. Yes, you want to ask for a referral to one of three options. And this is where knowing your local resources is critical. You've got to start reaching out on this journey. In this next section, we talk about travel companions. You got to learn who's out there. There are three physician types that you're looking for. Number one, a geriatrician. Geriatricians tend to be better able to manage the complicated situation for an older adult. So their main job is to work with older adults. The second is a neurologist interested in dementia. Now, listen to what I said, a neurologist interested in dementia, because if it's a neurologist who's interested in migraines, or a neurologist who's interested in Parkinson's, or a neurologist who's interested in whatever, it has to be somebody who is curious and interested about dementia. Otherwise, you're going to get a short shrift, short through the office. Well, it's probably dementia, it's probably Alzheimer's, and I'll start them on some Aricept. And you don't really need to come back. A local doc can cover you. Okay? The third is a geropsychiatrist who is interested in something besides medication management. You got to have somebody who's curious and wants to help the family and the individual live life worth living, not keep them quiet, keep them contained, and keep them managed. You got to work with a geropsychiatrist who is interested in living life once the disease happens. Because otherwise there are lots of geropsychiatrists out there who are majorly into med management, not into education, not into learning, not into figuring out how life can happen. So you're looking for some specific support structures around in order to make this work well for you. And they're out there, but they are not as common as we need them, and there is not as many as we're going to need over this next 10 years, 20 years.
Would they be more effective for somebody who's quite well along?
Yes. They can still be helpful because as the disease is progressing, they really need to know, okay, how do we look at, okay, her kidneys are starting to give her trouble. Okay, well, given these other situations, hang on, let's not get too carried away here. Hang on, maybe we should back off of this med first before we do that. Because if you just go straight to the kidney doctor for a specialist, they're going to do everything they can for the kidneys, but they aren't used to the dementia. So they're now giving them something that's really causing their stomach to be distressed, and they're peeing all night long while they're balanced when they're getting up. So yeah, you want somebody who's going to know how to manage that. And even if they turn it back to the internal docs, the general medical docs, we've got to get people accountable for what they're doing instead of a quick in and out of the house.
Incontinence goes along with that?
Yeah, incontinence is going to for sure be a big issue. It's going to start to be a big issue. Yes?
What's the best way to really go about doing that, to find these doctors? I've been on a path for 2 years.
And this is where what you want to do is you can't ask who's a good doc, because they would get in trouble if they did that. Who have you heard from other families gives a good evaluation? Because what they are allowed to tell you is what they've heard from other families. What they can't do is make recommendation from that organization without potentially getting themselves into legal trouble. But they can say, I hear back from my families that when they went to see Dr. So-and-so, he actually did this eval, and then he scheduled a follow-up visit. And that seemed to be very beneficial. Yeah, and so you can get that from Alzheimer's Association, Alzheimer's Resource Center, caregiver support kind of networks, Pines of Sarasota. Ask around, and that's where you want to start getting hooked into the system instead of trying to do this on your own. Everybody thinks they're all alone. In fact, you got huge numbers out here.
You also only mentioned psychiatrists. You didn't mention psychologists and social workers.
Absolutely, but for making the diagnosis and the medical management, getting the diagnoses, I mean, you've got to get to one of those guys. Yeah, once you're done with that, then the support, yeah. And it's very possible that that would not happen. So what do we want to do? Number one, be supportive, be an advocate. Work out your health care support. In other words, your health care power of attorney, check with your doctor, raise your concern, possibly get a neuropsych assessment. Consider seeing a specialist, geriatrician, a neurologist, a geropsychiatrist. And when do you want to look for a second opinion? Because sometimes even with that, if you didn't find the right neurologist, if the geriatrician was busy, if whatever happened, when you feel like what we talked about did not happen, if that didn't happen and you're in the early stages of the disease, you might want to get somebody else because this is going to be a long journey. And you do want to make sure you're on the right pathway. When you're feeling unlistened to about the concerns that you've raised, you need to think about a second opinion because you're going to be in this for the long haul. This is the old model of the doctor-patient relationship is being modified. And there are some docs who are not particularly good at working in a triangle mode, at figuring out, in order for me to treat you, I'm going to work with you. But I'm not going to look at you when I talk about your dad. I'm going to talk to your dad, but then we're going to schedule some time either on the phone or separately to do a follow-up and say, so tell me how you're doing. Yeah, so tell me what happened when you all did that. You know, if that's not happening, either with his nurse or him, you may need a second opinion because this is a long journey to try to do this without support. Okay? When you're not offered options that seem reasonable to you, when you think or feel that the MD is not skilled enough to do a good job at managing the particular situation you're in, and I will tell you from lots of experience, Lewy body, frontal temporal dementias, mixed picture dementias, and dual diagnoses almost always require special management. The general practice docs are just not ready for this. They don't have enough energy and time. They're pulled 20 different directions. They're not keeping up with all the pieces. It's very unusual to get a general practice physician who can manage those complicated ones because they don't even know what they are. What's Lewy body? I don't know. It's like Parkinson's, right? Parkinson's plus Alzheimer's. No, it's not.
But isn't it the truth that the vast majority of these doctors are managing these cases?
Absolutely. So what do we have people on? The most common PRN across the nation, Ativan. Ativan followed by Zyprexa. That's an anxiety drug. And what it does is increase the risk of falls, somnolence, dehydration, incontinence. Now, does it have its place? Sure. But do you know what else you should be doing before you give the Ativan? Do you know what we need to do to the environment, to the caregiver, to the structure, to the day? No, because nobody ever talked about that. All they said is, here's the Ativan. What should you do? You need to keep a top 3 priority list every time you go to the doctor. You need to say, what are my top 3? Here, doc, these are the top 3 things I need to find out while we're here today, and this is what I need to know before I leave this office. You also want to keep a medication log that lists everything they're on, what it's for, what the potential side effects are, and everything. And what's the dosages that you're giving, and when are we giving it? So when the doc is looking at the third piece, which is a behavior log or care log, you can look at those 2 pieces. He can look at those 2 pieces of information and do a comparison and go, you know, when we started this Detrol, it seems like she actually has been worse on that, and it looks like you're still having the same frequency of urination. Let's back her off. I'm not sure it's doing us any good. Now, we up the Ativan. Ooh, maybe we should drop it back down. This is where, if you have these pieces of paper and this information, it's going to make a difference. You need to be willing to listen, not have your mind set in stone. This is what I want. I want her X. I want this. And instead, tell me what you think. This is what I'm thinking. But you're working together with the care provider. You're willing to be an advocate. In other words, when they say at the emergency room, let's put her on some Ativan and see what happens. Whoa. 2 days ago, she was able to sit and actually watch a TV program and tell me what just went on. She was able to do this. She was helping me with laundry. You see her. This is how she's been for the last 24 hours. No, we are not going to just put her on Ativan and see how it works out. Absolutely not. You figure out, or I will be calling somebody to help me get this done. This is not all right.
I just feel there is such a need in the emergency room.
Oh, it's huge.
For doctors to...
Doctors, nurses, care support,
Here you bring somebody into an unfamiliar environment, and, they
Strap them
on, they want to put them in a straight jacket because their behavior's so bad, but they're so frightened to hear all these strangers poking and pulling and they don't have a clue. I know. Someplace they need to teach.
You're preaching to the choir. The problem is, and I will tell you, I go all over the nation doing all kinds of training. The hardest group to get attention, physicians in general, because they think because dementia there's no cure, nothing's changed. And getting them to really listen long enough to hear, oh, it's very different. Oh, well, they didn't know that. As soon as you can get them to listen, they're suddenly like, oh, wow, I didn't know that. Gosh, I need to know that. My practice needs to know that. But the other group is ER in general. And yet, 1 out of 3 ER visits has to do with somebody over the age of 65. I mean, it's a huge problem. You're absolutely right. It's a huge waste of money that we're putting into this and not getting what we need out of it. And it's a huge drain on everybody.
But in defense of ER staff, ER is probably not the place. You left it
Absolutely
too long,
not.
and then something got dangerous, or there was a serious injury, something happened. This should have been a medical appointment to a specialist, a second opinion, and all of that, aside from the ER.
Right. But what happened, and I agree with you, but here's what happened. When I called the doc, he said, well, take him to the ER because I don't have time, and if it's serious, they're going to have to see him anyway.
And that's the wrong doctor.
And I wish we didn't have very many of them, but they're all over the place. Be willing to try and try again and be open to hearing from others. That's the key pieces of that puzzle. So that's how you get started. Feels like we've already been down the journey, huh? That was just getting started. Who else do you need? Because this is going to be real lonely if you try to do it alone. So let's talk about who you need. The 2 major people on this journey is you, the care partner, whoever you are, and the person with dementia. Both of you are on this journey. But you're going to need a team to get through this. This is not a twofer. You're just not going to be able to do this alone. And there are 2 time frames that you want to consider when you're building your team. The right now and the future. So you need to think about your team for right now, but you also need to be thinking about the team for the future. Who are you going to need in the future? For right now, if you are really in the earliest stages, it's just MCI or it's just aging and you want to do it well, here are some things. Right now, what's okay that's happening right now and what's not okay that's happening right now in your life? So you want to be asking those questions. What's going okay and what's not going okay? If you were in the very early stages of the disease, we can be asking those questions. That's what we need to be asking. What is not happening that you feel like needs to be happening? What's missing? You also want to set some priorities separately. You and the person with dementia, set them separately. What's the top 5 things we want to do? And then bring them together and see how far off you are. Because if you're saying, well, I want you to cut down on your sugar, and I want you to reduce, and you need to lose about 15 pounds, and I want you to get more active because you need to be out at the church, and, I wish you would get more involved in. And they look at it and go, well, I don't want to do any of that. That's not what I had in mind. You 2 are going to be having trouble from day one. You want to keep what works, and you need to decide on what your top needs for change are, and pick it and start it 1 step at a time. When people have early things going on, you can't do wholesale change and think it's going to go well. This is where what you do is you go and you move them. Well, come on, Dad died, let's move you down with me. And it blows up in your face. And what you get is, I want to go back home. I'm not going to stay here anymore. I said I would stay 2 weeks, and that's all. Or if you move in with me, get out of my house. I'm tired of you being in here. You need to go get a job. I don't want you in my house. I don't need you in my house. Get out of here. Or if you're suddenly trying to switch roles, give me back the checkbook. Why are you taking the checkbook? But if you think you can make these big changes for that person and not have pushback, you're nuts. And I'm not being ugly to you, I'm just telling you. Because if I've always managed the money and all of a sudden you think you're going to take my checkbook, it's not happening. I'll see my lawyer. Yeah, I will. I'll go see him. You won't do that now. And because it's early on, guess what? I'm still competent to make the decision. You can't make me stop. So this is where what you may want to do is learn a new strategy. Hey, Dad, I know you always manage the money, but if anything were to ever happen, I don't even know what you do every month. I have no idea. And you put me down as financial, and I don't have a clue. This month, could we sit together? Could you show me how you do what you do? That'd be so helpful to me, and then I can keep notes of it. Now, what did you get permission to do? Eyes on writing checks. Eyes on managing that money. Now, you got to be real careful when he's messing up to not go, oh, Dad, oh my God, you just wrote a check with another zero. Oh, no. You say, oh. Now, so that bill was for 1,000 or 100. Which one was that? Oh, it was 100. And what if you go over here, you got, oh my, you going to give him extra? You going to give him a little bit? Tell you what, Daddy, why don't we pull that check, write void on that one, and let's do another one. That's a real different feel than, you're not safe to have that checkbook, Daddy. Give me the checkbook. Don't you start that. Do you want to end up poor? Do you? And what we do is we end up in fights with people because we don't know how to do one step at a time. We try to swing the pendulum give me your meds. You made too many mistakes. Hand them over.
I'm not.
Yes, you are too. And this is particularly bad when she used to be a nurse. Okay. You know, this is where, let me just ask, how many people, when you were 16 and you pulled up to an intersection and the light turned yellow, when you were 16, how many of you hit the gas? Raise your hand. How many of you, when you're 75 and you pull up the intersection and the light's turning yellow, jam on the brake?
How about red in Sarasota?
Well, Sarasota is a whole different world when it comes. I will tell you that I feel like I take my life in my hands when I drive in Sarasota. You have the higher per capita nationally. Let me just tell you something about dementia and driving as long as you brought that up. Dementia and driving across the U.S. and Canada, approximately 40% of people in mid-stage dementia are still driving. I think in Sarasota it's closer to 100. I mean, it's pretty amazing. But this is a huge problem because when they look back over insurance claims, they track back, and people who have mid-stage dementia and are still driving are twice as likely to have an accident with serious injury. They're 5 times more likely to have some sort of fender bender incident, violation. Okay? And they are very likely to have reduced reaction times and rely on the front seat partner for safety. They are relying on the person next to them to cue them up to whether what they're doing is safe. My personal rule is if I would not put my child in the car, that person should not be driving. If I wouldn't put my grandson or my son in the car with my mother, of course, let me drive with my grandfather for ages. She just told me to tell him earlier when the stop sign was coming up. But that was over 50 years ago. See, there was a reason. Back then, we didn't know he even had dementia. We thought all old people got like that. But the point of this discussion is to help us realize by the time most of us know we're on a journey, we're so far down the road that we're fixing problems we've caused without even realizing we were the ones that made it be a problem. They don't like us. They don't want us in their business. They're feeling awkward about what we're doing. They don't trust us. They think we're out for ourselves. They're accusing us of wanting people to stay in the house for no good reason. I'm okay. You want my money. What did you do with this? And you don't realize how far in the disease you are. And so you've created this monster that now it comes to personal care needs, and they're having none of it. You're not going to help me take a shower. I know when I don't need to change my clothes. You get out of here. Leave me alone. And what happened is we didn't know we were on the journey. You need to know some things about yourself if you're going to be a care partner. Are you an introvert or an extrovert? Are you logic and rational or emotional and feeling? Are you big picture or detailed? Do you like to plan it out or just do it? And you also need to know this about your person you're caring for. Because if you are not a good match interactionally, because you are not the same at all, you need to start recognizing that may be a big bone of contention. Because if I'm a strong extrovert, I love to go see people, I want to get out, I like being around people. The person I care for is an introvert. Just you go, I'm going to stay home. I don't want to go. I said no. And you argue and fight simply because they're an introvert and you're an extrovert. If they like to plan things out, here's what you're going to hear when there's dementia. Well, what time are we going? When is so-and-so coming? When is that? When is John coming today?
Oh, soon.
What time?
In about an hour.
From what time would that be?
Around 1 o'clock.
1 o'clock today? Mm-hmm. So what's going to happen at 1?
We're going to go out.
I thought John was coming.
John and you and I are going to go out.
Well, is he coming so we can go out?
He is.
Well, what time is he coming?
1 o'clock.
Today?
Yes.
Oh, well, when did this get set up?
Well, we thought...
You can feel yourself falling in the rabbit hole with me, because I won't ask you once. I ask you over and over, and I want all these details and all these specifics, and you just want to say, what does it matter? You won't remember it right after I tell you. Oh! And you find yourself, because it's like, Mom, what does it matter? We'll just have a good time. No, I need to know what time we're going to be coming back. I don't want to go somewhere and not have everything. Wait a minute, let me get my pocketbook, and I've got to put my Kleenex. I need 3 Kleenex. Let me get 3 Kleenex to put in my pocket. I want an extra shirt. Let's get in the car. Can we not just get in the car? Let's just get in the car and go. Well, where are we going? How long will it take? What time will we be there? When are we going to get? And all it is I like lots of detail, and I want to plan it out. And you don't want lots of detail. You're just a big picture. We'll go have fun. We'll go to the beach. Which beach? What does it matter? You don't even know which beach we're at when we're there. I mean, you find yourself just losing it because of a personality difference. You've got to be looking at this, and you also want to look at this for helpers you bring in. Are they a good matchup or not? A real strong extrovert wants to talk to the person all the time. Holy crap, she never shuts up. I mean, why did you bring her in here? All she does is run her mouth. She doesn't do a damn thing. I mean, she hasn't done anything since she's got here. And if that woman tells me one more time, I swear to you, I know when I have to pee. Do you think I'm stupid? And it's all about personalities. Okay? You also want to look at building blocks. What kind of things do people need to do? They need things that are going to energize and relax, re-energize. They need things that make them feel productive and valued. They need to feel valued even though they have dementia. And they're losing so many opportunities. They can't manage their money. They can't manage their meds. They can't cook. They can't run that car. They can't drive. They can't do this. And all of a sudden, what do they do with their time? Well, they don't know. And we say, well, tell you what, I'll fix supper. Well, what am I going to get to do? Sit there and watch TV? I have cooked for 80 years. And you're telling me I'm not allowed in the kitchen? Bullshit. Get out. Okay? Also, we want some just because fun activities, but they've got to be ones that I can still enjoy. And you've got to really be thinking about what can I still enjoy and what can I. And finally, I need time to take care of myself. And you need time to take care of yourself. Self-care activities. Whether they're fitness activities, like exercise, whether they're brain activities, things that make me think and use my brain, reading, talking about what I've read. But we need this balance, these building blocks. And we want some of each, not just a whole bunch of something. We want to get into a routine and stick to it. People with dementia can't do surprises. They don't like surprises. They don't like these huge, big gatherings y'all think is going to be great. Oh, a whole bunch of these people saying, you know me? Who am I? Remember me? Remember me? You know me. Look at me. You recognize me. Who am I? You know me. Shut up. I don't know you, and I don't care to know you. This is where, if you're going to have a large gathering, you got to keep it real socially light, and everybody's got to be cued ahead of time what to do and what not to do. Hey, it's Teepa. How are you doing? Not, who am I? Remember me? I used to live by you. Remember Aunt Charlotte? Who am I? I don't know, but you're going to get hit. Okay. You also want to look at changing up just a little bit, maybe going out for ice cream every now and then, but not necessarily a 4-course meal. It's too much. Can't handle it anymore. That's way too much stuff for me. And as the disease is moving forward, you're making shifts and changes. Time in between to chill out. It takes me a lot longer to come up and go down anymore. I can't just go from one thing to the next thing to the next thing. We used to be able to go out in the car all afternoon. We'd go to the shopping center, and then we'd go to the grocery store, and then we'd go and do laundry, and then we'd go do this, and we'd do that, and we'd do that, and I'd come home, and then I'd rest. Not now. Going out once is enough. And then I need to come back and chill out for a little bit. And maybe we go out tomorrow and do the next thing. And maybe we go out the next day and do the next thing. Every afternoon we go out, but we don't go out and try to do 5 things at once. And you care partners, you got so many things on your plate, you want to try to get everything done at once. Ain't going to happen. I'm going to drive my heels down. We also want some old stuff and then some new, some for me and some for you. And that's the bottom line on that. Things that are going to help. Smoking, problem. It's going to be a problem. The sooner we can get that halted in the disease, the better. Because as the disease progresses on, and I don't remember where I've put things and what's going on, there's a very high risk of fire, very high risk of burning things down, burning things up, getting myself in trouble. I will also increase frequency of smoking, and I'll become a 5-pack-a-day smoker. Because every time I smoke, I forget that I just smoked and I want to smoke again. And I'm actually craving the drug because the nicotine actually bumps me and makes me feel good, and so I'm constantly wanting that high. And I become a super chain smoker. I need a cigarette. Give me a cigarette. I need a cigarette. I need a cigarette. Please, please, give me a cigarette. Please, why are you doing this? I haven't smoked all day long. And the nicotine stains are just phenomenal. So if you can catch it early in the disease and start to make the change. Early in the disease is when you want to lose weight. Not in the part of the disease when you think you want to lose weight, which is mid-disease. Because that's when they're eating time after time after time because they don't know what to do with themselves, so they eat. They eat and they eat and they eat, or they won't eat. They won't eat. They won't eat. So they either gain weight or lose weight in the mid-disease time because they think they already did, or no, I didn't, I'm not hungry. But when we want to do is lose weight early on before it becomes an issue. And the best way to work on losing weight is increase activity level. Socialize, de-stress. And for de-stressing, I'm not just talking about the person with dementia, I'm talking about you. If we don't get you de-stressed early in the disease, you aren't going to be able to help the person with dementia. We've got to get your stress under control because what's happening in your brain, cortisol levels are growing. They're going up. Cortisol is a negative stress hormone that affects everything. It affects your organs, it affects your heart, it affects your ability to process insulin. It affects your ability to process information, to visually regard, to make good choices and decisions, and to think about your impulse control is controlled by cortisol level. Cortisol goes really high when it's flight, fight, fight kind of a response. You really need to pay attention because it's an emergency situation. Here's the problem. When you're a caregiver for somebody with dementia, you're living in that mode all the time. And when you do it all the time, your brain was never designed for that. Your body was never designed for that. And you start falling apart. In 40% of cases, we'll lose a caregiver before we lose the person with dementia. You can't do this constantly and not pay a price. So you've got to de-stress. You've got to get enough sleep. You've got to get your sleep apnea and your depression treated if you have it. Bad news about caregivers, about 50% of you have untreated clinical depression. You're depressed. The reason you're yelling at mom, sit down. Sit down. I don't have time for this. I need a cup of coffee. I'm going to eat that cake out there. I'm going to eat 5 of them. I'm depressed. I have that atypical agitated depression. No, we're not changing anything. We're leaving it like it is. You think you're safe? And I'm the caregiver. This is not a good sign. This is not good. And everybody's saying, you need a break, you need a break. I'm fine. I'm just going to keep on doing what I know how to do. Nobody else steps up. It's like, whoa, time out, time out. Okay. I will also tell you, you want to watch your blood pressure and your diabetes. High risk both for people with dementia and caregivers. Blood pressure, it's a biggie. Cortisol levels go up, blood pressure goes up. You guys run pressures, all of a sudden you're on hypertension medications. All of a sudden you're taking adult onset diabetes medications. It's all because you're a caregiver. And be careful about the meds you do take. Even the over-the-counter stuff. Watch yourself. Because you're going to tend to, at times, over-medicate. Yes?
Is cortisol a blood test?
They can actually do a test on your cortisol level. They don't traditionally, unless they're doing a study of some sort, but they can actually look at your cortisol levels. Mm-hmm. You don't want them running high. Tell you that. It builds body fat in the wrong places, organ fat. So some specifics about this journey. Make new friends. Form partnerships. Keep old familiar contacts when they are learners. If they won't learn how to help, kick them out of your life. I'm not being ugly, but you can't drag people along who won't learn what you need them to learn. if they keep coming in and saying, your mom looks so good, how's she been? And you work with them and they're still coming in and say, I bet she's wearing you out, and she's sitting right there. Time to knock them down out of your life, because they are not helping you. They are stressing you out, and you're not only caring for your mom, you're caring for that person who's coming over making you nuts. Because when she leaves, Mom's, I can't believe she didn't even look at me. These people, that's what I don't like about them. I'm not going to church. Great. Okay. You explore volunteer opportunities. Sometimes with the person with dementia or you can find ways to get away and do your outlet in another way. Use old skills and routines in new ways. Give it a try more than once. Start low, go slow, build skills. Where'd you hear that before? Join a support group. Try a support group at least. If it doesn't work for you, okay, but at least give it a try. Being around other people who are in similar situations can lighten your load if it's the right kind of support group for you, because suddenly you can go, I'm not in this alone. Oh my God, you mean other people are going through this crap too? Suddenly it can feel good. For some people it's not a good match, but at least give it a try. And not only for you, for the person with dementia. There are now, in most areas, some support groups for people who are living with dementia. And they need support groups. They need to be able to talk about what's hurting and what's causing them distress and what's making them angry. Many of these folks can do that with the right leader of a support group. I mean, I've led these support groups. It's amazing. I mean, people are amazing. They say, I hate that I do this to my daughter, but I turn around and do it every time. I wish I could tell her that I wouldn't do it again, but I know I'm not going to be able to make that promise. Now, when the daughter heard that, now Dad couldn't say it to her directly, but when we talked about it, and I said, can I tell your daughter that? Well, you can tell her, I can't. She was now able to tolerate a lot more because she knew her dad got it. He couldn't hold on to it, and he knew he wasn't going to not be able to, but it enabled her to take that step back and not take it personally and realize her dad was still her dad. He was living with dementia, but it was still her dad in there, and he was trapped. And that gave her the strength to make some changes.
So you're suggesting a support group for the actual patient, not
Yes.
for the caregiver?
Early in the disease, support groups for people who have the disease are actually very beneficial. Nice outcomes for those. We're starting to get the data in on that. They know something's up. And depending on the support group, it can be really beneficial for them to have an opportunity to work through this. They're losing everything. I mean, and some of them know where it's going. They've had it in their family. They deserve a chance to talk this out. And some of them have very limited language, and that means you need a skilled leader of the group who knows how to help people who don't have a lot of words maybe. But it's possible to do it. And finally, y'all need to get away from each other some. You need to figure out a way time. And the problem is, if they're nervous, they want you around them all the time because you speak for them. If you're a really good advocate, they want you there all the time. You've got to recognize in order to be a good advocate, you've got to step away a little bit. You can't do it 24/7 and sustain it. It's a long journey. You're asking yourself to sprint a marathon. We're going to find you along the route, but you're not going to make the run. I mean, there's no way to sprint a marathon. I don't care how good you are. I actually want to take you through what are some issues that are very likely to occur through the course of this disease. In most cases, it's a case of when, not if. You're going to hit some potholes. You're going to take some detours. So one of the greatest potholes and detours you might have is hospitalizations. It is estimated that 50% of people with moderate to severe dementia go to a hospital at least one time every year. And you'll be there at least once, whether it's the emergency room or whether you actually get admitted. But on average, 50% of people with moderate to severe dementia are there at least once a year. Okay? What do you need to know about that? Because hospitals are actually the most dangerous places in the world for people with dementia. They are very, very dangerous places. They were never meant for people with dementia. They do not do well with people with dementia. They don't actually process people with dementia very effectively. Hospitals are really serious places. I will tell you, this is an example in New York where they keep their stats pretty significantly. Dementia is the primary diagnosis that people come into the hospital only 9% of the time. However, it's a secondary diagnosis, which means that's not the reason they came in over 45% of their admissions. So close to half the people who go into the hospital have dementia, but it's not why they're there. More women than men with a diagnosis of dementia were admitted after age 65. Now, in most cases, what that means is their husband's already dead, because males die before females as a rule. So we have a lot of women with not a lot of support system in place having dementia in the hospital. Okay? If an emergency or urgent admit occurs, the incidence of dementia is above 50%. So over 50% of emergency admissions in a hospital have dementia on board. If dementia is the diagnosis, they are 3 times more likely, regardless of where they came from, to go out to a nursing home. If we compare them to people without dementia, they end up in nursing homes 3 times rate. I will also tell you, if they have dementia, they're 25% more likely to need support services when they go back home. Now, how many of you go to the hospital thinking you're going to come back home worse than when you left? Yeah, well, see, you're smart. You know how this works. Most people, when you go to the hospital, what's the expectation of being in the hospital? You're going to get better. I mean, the whole point of going to the hospital is so you'll get it fixed and you'll be better. But when you have dementia, you actually go downhill more frequently than you go uphill. Okay? I will also tell you that 30 to 40% of the time, they are likely to have an actual measurable functional decline while they're at the hospital. They will lose skills while they're through hospital. They go from being continent to incontinent. They go from being independent to dependent on meals. They go from being this to this. They lose skills while they're at the hospital. And 50% of people with moderate to severe dementia, as I said, go to the hospital every year. Now, if we compare people with dementia to people without dementia when they came in for a hip fracture repair, okay, the reason they're there, they fell, they broke their hip. They have the same number of procedures in both groups. This is an actual study. Same number of procedures, no difference in the numbers of procedures. They had the same types of procedures in each group. People with dementia got 1/4 the pain medication of people without dementia. 1/4. They got 3 times the antipsychotics.
Keep quiet.
Uh-huh. Because if I have a hip fracture and I have dementia, I'm first day post. I still have my catheter in because they can't trust me to tell them when to take me to the bathroom. So the catheter's in, it's across my thigh, hanging down there out of the way. I'm in a jerry chair parked up near the nurse's station. That is because if you leave me in my room, I've tried to climb over the rails twice. I'm a fall risk. So they've got me up in a jerry chair, tipped back. I have a great big foam wedge strapped between my legs to keep me from crossing one leg over the other, because otherwise I forget about this thing about hip precautions and I keep crossing my leg over. They've tipped me back. They have the tray on because they don't want me to get up. Okay? I still have an IV in. It's the 3rd IV they've put in because I've ripped 2 of the suckers out. The reason it's in, they can't get me to take drink and fluid and food the way they want me to, and they're trying to keep me hydrated. Plus, they got to give me meds, and I keep refusing them. So they're putting them in the IV. So I'm in a gown. I'm up there. I'm up at the nurse's station. I'm tipped back. They've got the tray over the table. They have lightly restrained my wrists. Not heavy restraint, light restraint. But why? They don't want me pulling that IV side out because it's the 3rd one. Okay? Here I sit. Hey! Hey! Mama! Come here! Hey! Where's my mama? Hey! Hey! Help me! Help me! Nurse! 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 Hey! Hey! Help! 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 3 other patients on that unit. Shut her up! Shut her up! I'll knock the shit out of her. I'm sick! Damn it! Tell her to shut up! I can't take this anymore. Hey! Hey, nurse! Oh my God! Oh! It's a snake! Oh! Oh! Ow! He bit me! I just pulled out the catheter. You got it. So, I'm obviously hallucinating, yelling for my mother, pulling a catheter out, thinking a snake bit me. Time for the antipsychotics.
And that's all situational.
And it's all situational. What you're seeing, if you were hurting and you needed help and you were trapped and you were lost in time, and when's the highest rate? We got rubies and ambers and emeralds at best. Who you want? Mama, help me. Help, help me. Is anybody coming? Help! So I'm just getting louder. Hey! Obviously nobody's listening. What am I also giving? Yeah, I'm pounding on things. What if you're hurting? Have you ever hit something when you hurt to make the hurt not hurt so much? Yeah, I'm hurting. And what I end up with is an antipsychotic. When was the last time you heard that actually improves pain control? Yes.
Yesterday, we got a call they were looking for a team that worked with a dementia patient to get them prepared for surgery. Mm-hmm. Is there such a thing, and does it work?
There is such a thing. It's very rare. It occurs in larger tertiary care centers where they have discovered if you don't do this, you're in trouble. Because what we need to do is we need to help them get ready for surgery, and then we need to be there post-surgically so they don't over-medicate or under-medicate. So that doesn't happen. This doesn't need to happen. If we have somebody with that individual, we can give sensory input. We can say they need Tylenol. I will tell you, a lot of our folks with advanced dementia do fine with Tylenol. They don't need central acting narcotics. They want to dump a bunch of narcotics on them that depress their respiration and so this is where we're doing a balancing act. Yes, they need some pain medications, but no, it doesn't necessarily have to be heavy duty. But it needs to happen before they get to that stage, because if you put Tylenol on that, is that going to get better? No, it'd be like putting a Band-Aid on a gaping wound. So we need to meet the other needs. This person is probably also not feeling hydrated. Why? They're not getting anything by mouth. They've got it stuck in their arm. And obviously that bothered them. That's why they kept ripping them out. So instead, now the statistics that I will tell you is that when somebody goes in for a hip fracture repair and they're moderately to severely demented, the statistics are 1 out of 4 will die somehow during that whole process. From the time they have the hip fracture through rehab, they never come back, they die during that process, during the course of that. Things go bad and they get worse. Okay? The other statistic, 2 out of 4 will come back at a 1 level less mobility. So if they were independently walking, now they're using a walker. If they were a walker, they're using a wheelchair. They never go back to that prior level of ambulatory skill. And only 1 out of 4 recovers. That is miserable. That is miserable. For as much money as we put into this, that's miserable statistics.
Might that be the same for, say, a shoulder fracture?
Yes. Same deal.
Might not be hip related at all.
It could. It's basically the same thing. A non-union humerus. I mean, and they get a lot of shoulder fractures because they don't protect and they go down, whereas people with more intactness get Colles fractures. Because Colles fractures happen when you're emeralds or diamonds because you're going to catch yourself. But past that, they can't. So a lot of shoulder fractures, head injuries. They do terribly. Here's the other stats of note. Feeding tubes are still being placed. You'd think we'd quit that. Doesn't work, doesn't help, but we're still doing it because at the last minute, we haven't really talked too much about it. The doctor says, tell you exactly what he says. Listen, it's not looking good. Your mom's not drinking much. She's not eating much. I can tell you for sure if we don't get something in her, we're going to lose her. Okay? What do you want to do?
Put the feeding tube in.
Yeah, why? Because it feels like giving up. Instead of saying, well, now, tell me what's going to happen if we do put the feeding tube in. Well, actually, for right now, I can't really tell you what's going to happen. Because, actually, when we put feeding tubes in people, what we know is many people, because of this forward flexion and because of this tightening up, what happens is when we put the food in the tube, it actually goes up the esophagus, and ends up coming back into the lungs. And now we have acid stomach contents in the lungs. The other thing that happens, because they're forward like this, some acid from the stomach follows the track of the feeding tube out to the surface of the skin. And this acid from your stomach is incredible stuff. I mean, it can really break stuff down you wouldn't believe. So what do you think it does to the skin? Bothers it. So guess what I'm going to try to do? Pull it out, because it's really irritating and annoying. So now I'm tied down. And guess what I still figure out how to do? Okay? And so then you tie me down and mess with it. And this is where, when doctors say that, the way they sometimes say that, we feel like bad people when we say, you know what? I don't want the feeding tube, but I do want her to be comfortable. What do we need to do to make sure she's comfortable? If this is where we are, how long would you anticipate us trying the feeding tube before we decide to discontinue it? Oh, well, I have no idea. I can't tell you that. I mean, that might be, but we can put it in. Sure you can. This is where that advanced health, this is where having that discussion from early times, if it ever gets here, this is what I want, this is what I don't want. Offer me tastes of water, even if it's going down the wrong way. If I'm not uncomfortable, offer it to me anyway. And don't give me thickened water, okay? You hear me? I'm writing you right now. I do not want thickened. If it goes down the wrong, if I cough a lot, then just moisten my lips. You know why I can say all this? Because I've been there and done it. And I am telling you, I've seen it, and I know what it's like, and I know me. And this is what I'm not going to want. You actually take thickener and you just put it in water so it feels sort of like a gelatin thing. But if no one has ever actually tasted it, before you give it to someone, you need to actually taste it to realize that it really is different than water. I mean, it doesn't taste anything like water. It tastes like your slime. Yeah, it's sort of like that Biotine stuff where they on the tea. Oh, try this. This will be nice. Yeah, go ahead. Put that crap in your mouth. Let me see what you do after you put it in. Because I put it in when I took care of my mother-in-law because she had dry mouth. And I thought, okay, well, I want to know what this is like. I went, oh, shit, no wonder she don't like it. Oh. And then once you get it in there, you can't get it out. I mean, it's like, oh, yeah, I'll try to get this out of your mouth. This is awful. Oh, my God. And I tried to, I had paper towels. I was like, get it off. Yeah. And then I went to drink a whole bunch. You're like, oh, well, that would help. But that's me. And I'm saying that's my personal choice. You all have your own, but what I'd say is at least have the discussion.
Well, I went through this last Friday and had a discussion. And I looked at DNR. So they said, well, feeding tube would go against DNR. I said, but then it makes the decision
easier.
Say, what can you do to make her comfortable? So they went with supplements and so forth. And they talked about hospice.
Good.
And yesterday she said, oh, I really need to get out of here. We got to get out and have some fun.
Good job. Isn't it? I mean, like, oh, it'll be over.
98.
Yeah, it's like, well, she's not quite ready. There's something not done. She's working on it, but she's all not quite ready to go yet. She's what you'd call a catbird, as we'd call it up north. No. The problem with getting fluids in through the skin is that it goes to the wrong places because the central system is not operating anymore. It's not really saying, you know what? Oh, yes, I'd like that fluid to go to your kidneys. I would like that fluid. It just sort of sits in the skin, and it starts to swell things up. You will tell when we're getting in those late stages. The fluid doesn't go where we want it. It gets in the lungs. Oh, the epidural? They're not actually in that kind of pain. I mean, that's not what... Yeah, I mean, what we need is often just a laxative. We actually need a suppository that actually just has Tylenol in it sometimes, if they can't. Right, so a Tylenol suppository where you put it up through the back end. Yeah, that's all that you need. They could, but one of the problems is it tends to depress breathing, and that would be considered an active assist, and so we can't do that. That's a little Kevorkian. Yeah, so that's a little bit Kevorkian. Yeah. Here's what I will tell you. Advanced planning does help. Because if you've done advanced planning, there's greater satisfaction. And it's actually been studied. Families are more satisfied, caregivers are more satisfied because they feel like we've had the discussion and it's a reasonable discussion. The quality of care is actually described as better if we do this discussion ahead of time. When decisions are forced by immediate circumstances, there's more dissatisfaction with the decisions, and there's longer hospital stays where more procedures get done on people that don't change outcomes. And the survival at 3 months is no different from whether we did it or we didn't do it. Okay? Costs are incredibly higher. Now, if you're acutely admitted with a diagnosis of dementia, and it's the primary diagnosis, these are the reasons you come in. This is why people do go to the hospital. Number 1, pneumonia. Number 2, aspiration pneumonia. Number 3, UTI. Number 4, dehydration. And number 5, fall-related injury, either a fracture or a head injury. Those are the main reasons people are in the hospital with dementia as their primary. I will also tell you when dementia is a secondary, we got issues. The treatment of the primary condition is impacted over 75% of the time. So if I have COPD and I'm in because of a worsening in my COPD and I have dementia, good luck trying to get my COPD, because what do I keep doing with the mask? Taking it off, getting out of the bed, not doing what you asked me to do. Stays are longer. Functional losses are more common. Cost of care is higher. Outcomes are less positive, and additional acute care issues occur in over 50% of the cases. In other words, while I'm in the hospital, something else bad happens to me. New fracture, new head injury, new dehydration, new incontinence, new pressure sore, new skin tear. I mean, it's serious stuff. Acute problems connected to stays. Here's what happens while they're there. As a matter of fact, falls and fall-related injuries are the number 1 thing that happens to people with dementia in the hospital. Second thing, wandering and elopement attempts. They try to get out. Imagine that. These people are trying to keep me prisoner, and they shoot stuff in me. They're using me as a bunny. I'm not having it. I'm getting out of here. And they try to break for freedom. New onset of incontinence. For the first time, they're actually incontinent. And the problem is when they get incontinent at the hospital, they stay that way. They stay that way. Hospitals are very free with their using the catheter. And once we get that catheter in there, it's hard to retrain once that happens with great regularity. There's also acute confusion. They get delirium in the hospital. So they have acute confusion on top of their dementia. They're seeing things, they think of things, they're doing things that don't make sense, but it's all happening because of the hospital stay. They're in a foreign environment. They have skin tears and skin breakdown, physical aggression toward care providers. Now try to find a place for Daddy to live. Because now he's whacking people. Pulls out tubes and monitoring equipment. They're jerking everything else. What the hell is this? Gone. Off. My mom, when she was in the hospital, they decided, before I got up there, my sister-in-law said, I guess so, before I could get up there, a brain biopsy. They took her in for a brain biopsy. So she comes out of the brain biopsy. I get there, and so I'm getting in, and I get there, and before I can get there, they had the boots on her, to maintain the legs because they didn't want her getting clots. Okay, they put the boots on. It was a neurointensive care unit. They had 1 nurse for 8 folks because they had call out on nights. The doctor came through on rounds at 2 a.m. She'd been asleep. Came through, woke her up, asked her how she was doing, asked her, did she know where she was, what was going on. She was a little fuzzy, a little confused. Left. She was now enough awake that she knew she needed to pee. Couldn't remember to use call bell. Because how do you get help? Hey. She'd heard a woman across the hall the whole time we were in the intensive care. Hey, I need help. We'll be there in a minute. We only have 1 person. She had to pee. What'd she decide she should do? Get up and go. So she got up with her boots on. And she made it all the way there was real short distance, all the way to the bathroom. And she went to turn around and she ran out of cord. Same side of the head where she'd had the surgery. On the bathroom wall. She hit the wall before she hit the floor. And so then they put her on fall precautions. Okay? I came in and I said, physician, We need to talk. I want you to understand what you just did. What do you mean? What did you do when you went in my mother's room? Well, I was checking her. What time was it? Did you make sure she had been to the toilet? Well, no, that's the nurse's job. Not if you're waking her up at 2 a.m. and 8. You are the cause of my mother's fall. You personally are the cause of my mother's fall, and I want you to understand that. You need to know what you do matters. Guess what I was? A diamond, and I was pissed. Because there was no reason for that. You know, they were short-staffed. They didn't get the help they needed. My mom, in her typical mom way, always been independent, left the boots on, didn't check anything, woke her up. I'm the irrational family member. You got it. That was my job. So what's not working well when people go to the dementia hospitals, go to the hospital with dementia? Number one, they're real quick on the behavioral control stuff without actually checking out what's going on underneath that. The premorbid baseline measure of cognitive status is not taken. We don't know what they were like before they came. We don't even ask. Often it's rarely asked. It's not accurate. They're not screening for the 3 Ds at the start of the admission: dementia, delirium, and depression. What were they like? What's going on here? Is this new? Interpretation of verbal reports and behavioral symptoms are not being made. They just want to get them in, get them out. You know, oh, hip fracture, okay. Idea of acute versus general onset of change. Has this been something that's gradually been coming on? Is it a level change in dementia? Or is this something that's real different? Something's different going on here. And what's the protocol for monitoring the person when they have dementia or delirium? They don't have a clue. They put them on fall precautions. Elopement precautions. Okay? I will also tell you the use of the environment and the human resources are not there to prevent those secondary events because they don't have that in place. England is starting to put that in place. England is what they do is they have care people who go around, give back rubs, help people go to the bathroom. That's what they do. They just go around, help them go to the bathroom, give them back rubs, give them something to drink. Guess what? They've cut down on their falls phenomenally. They cut down on the injuries phenomenally. Why? Because people with dementia are trying to meet their needs in a foreign environment where they think they can't get what they need, and they're in an unfamiliar setting. Pain assessment and management needs to be done, and it's rarely done to effect. Here's my favorite. Are you hurting? No. So you don't want your pain medicine? All right, now you understand it's going to be a couple hours before I can come back. You clear about that? You don't want it now. Are you sure? Are you hurting? Okay. Resident refused pain medication. No complaints of pain. Is that accurate? No, what it was me not understanding. I cued. He followed my lead. He didn't understand a word I said. He was following my visual cue. I guess he's okay. CYA, well, that would be that, too. Communication systems that don't work. Call bells don't work for people with dementia. We need to quit asking people with dementia to do that just like we do with the walkers. I mean, it doesn't work. They can't use them. We're much more effective. One of the best things they do in some hospitals, instead of, which means you're trying to get out of bed, you know, because, ooh, crap, I'm going to get caught, which makes me more, let me hurry. What we want to do instead is, hey, Teepa, help will be right there. Have a seat. In a familiar, well-known voice. And there are actually systems now that can do that. So rather than fuss at them, it says, oh, wait a second, I'm on my way. Now, who are you likely to listen to? Yeah. And it gives staff a chance to get there versus, I'm out of here. Okay. In and out monitoring. Food tray comes, food tray leaves. No eating. They didn't even know it was a food tray. They certainly didn't know there was anything on there, and they couldn't find the utensils wrapped up in crap that they couldn't understand. And they played it. Ability to tolerate inactivity, isolation, and immobility. Oh, one of the good things they're good at, because you know how much comfortable all three of those are. So what we end up with is we blame them for what's happening. They have limited ability to interpret and tolerate the sensory experiences we're putting them through. So what do you need to do? And we could go on. There's more. More. But what do we want to do? Number one, we need to realize hospitalizations do happen. So you, the care partner, need to be prepared for that. Hospital stays are risky. You need to know that. It's not going to be an easy travel. Good luck if it goes well. It rarely will. Hospital stays are stressful to the staff and to family members, and standard communication monitoring systems are generally ineffective. So what do? Get ready. The Institute on Aging, National Institute on Aging and Health, has actually, we put together a whole booklet that's available for free online. It's called Hospitalizations Happen. And it has in there what to do. We just revised it last year, 2 years ago, I think. You want to put a hospital bag together just like you would when you got pregnant. The hospital bag has in it all kinds of things that the person with dementia will need, but also what I, the care partner, might need if I have to be there for a day or two. You know, because it's an emergency and I just have to stay. I have things that I need. Fresh pair of underwear for me. You know, maybe my cell phone recharger. Things that I might need. I need to drop, stop, and roll. I need to know what to put in my bag so I'm ready to go. You want that ready to go, because you never know when it's going to happen. You want to base it on my preferences. What do you need to tell me? And there's lots of stuff that go in that bag. Build a team, share the load. You need somebody to be point person for all the phone calls that are going to come in. You want somebody who's going to actually be the one to do the transport. You want somebody who's going to take care of the dog. You want somebody who's going to take care of the rest of your life while you're dealing with this, or who's going to get the people together so that you aren't there all the time and we share it out. When Dick's mom was in the hospital, it was 24/7 for us. I had nights and different people had days. We actually hired people sometimes to come in and stay with his mom. Because if we didn't, she'd pull the tubes right back out and we'd been back in the ICU. I mean, it was a disaster. Every time we'd turn around, they were wanting to give her more drugs, which caused all kinds of problems for her. We need to also look at our options, consider what is possible versus what makes sense, and pick what makes sense, not what's possible. Evaluate how it's going now, probable outcome, reconsider, and learn from the experience. Next time you may decide, you know what? We're not going to go. This is just such a disaster. This really doesn't make any sense. Okay? So, wrong way. Excuse me. This is that resource. And again, it'll be, if you get it online, if you go to the website, you'll be able to find it. It has it listed. It'll take you right to that. It's free. You can get multiple copies, share it out with family members. And then the next part of the presentation we're not going to get to, I want to talk about falls and fall reduction risk. So this is another very common pothole, and I have lots of things on there to help you as you're doing it. So again, the idea is you want to help with mobility, you need to know what to do. You need to know how to help. You need to know how to assess. You need to know what you're going to do when you do find things. And the reason I put so many of these slides on there is to try to help you. And the last second I want to take is to say to you, manage your stress. And I want you to take care of yourself, because you can't take care of somebody else if you're not taking care of you. And the reason you need to is this is hard work. Long-term exposure to stress affects your physical as well as your mental health. And over the 40% of the time, we lose you as a caregiver before we lose the person to the disease. We also know your emotional state affects the person you're caring for, and you are truly just as important as they are. So what do you need to do? Become aware of yourself. How are you doing? And then check it out. Are you right? Because some of you have very poor awareness of yourself, physiologically, physically, intellectually, emotionally, socially, and spiritually. My suggestion, you might want to actually look around and ask people. What do they think? How are you doing? How's it look to them? Okay. These are some stress indicators. Here's an emotional stress indicator. Some people find this one helpful. Who are you on that picture parade? Okay. And then what are your social stress indicators, spiritual stress indicators? And then step 2, think and remember, when was the last time you felt really good? What was going on? When was the last time you felt really miserable? Not because I want you to feel miserable, but I want you to think about, how did you get over it? How did you get through it? And what made it better? And realize how you feel is real. It's not good or bad or whatever. It's just what it is. Just like the person with dementia. And if you're having a hard time, think about what helps you, what you need, and what's missing. And try to get those needs met. Some ideas, pick one thing, take baby steps, get support, build a routine, check in on your feelings, and add something before you give up something. Does it sound sort of vaguely familiar? Whether you're demented or not. Believe it, not everybody is meant to be a hands-on caregiver for somebody with dementia. My husband loved his mom. He was a crappy caregiver. It wasn't due to lack of love. It was due to who he was and who his mom was. And he's a computer geek. He had her by the forearms when I came home, first day. Mom, I went into computer work for a reason. I don't like people that much. And I'm like, honest but true. She has sat in that chair and peed 8 times today, he says. And it's like, yep. Yeah, home care agency. You know, I know we were only going to use you 3 days. Yeah, I'm going to need you 5. Yeah, sure enough. Yeah, it's not working so well. Because Dick loved her, but he wasn't a good care partner for her. And there's nothing wrong with that. He managed the money. He went out, earned money, and we paid the person. And it worked just fine. And AB did a lot better with it, and so did Dick. So did I. You also want to look at some other options. Set aside a few minutes, use a timer. Breathe. Learn how to breathe. Y'all think you know how to breathe? You do not know how to breathe. You hold on to it. You never let it out. You don't let it go. Smile, laugh. Remember a good time. Do what do you get out of the relationship? If you don't find something good out of the relationship, because this is my question I ask caregivers, tell me what you still like about your person. And when I get, well, you know she's my mom, and I promised I would always take care of her. Time out. This is time for both of us to take a break, because the reality is, if you don't like the person you're caring for, this is a really dangerous place to be. You've got to like something about them, even if it's the smile. You know, this isn't my mom anymore, but I still like her. You know, or this is really hard. I can't think of anything. Then maybe it's time to take a break. Because there's nothing wrong other than not admitting there's something wrong. And it's time. The other thing I will also say in closing is that when people say, when do you know when it's time to place somebody? My answer to you is 3 months ago. Because by the time you're willing to ask me the question, you are fried to a crackly crunch. Because you hate admitting that you can't do this anymore. And you're asking permission. And I want to give you permission, but what I've got to say is, you know what? You've already held on 3 months longer than you should have, trying to keep up with this, because it's so hard to admit this isn't going to get better no matter what I give it. I mean, I can give it 120%, and it's still not going to make it better. It's hard. This is really hard. So look at the stress tamers I've provided you with. Some of them are real simple. Some of them are more active, depending on who you are and what you need. But I have like a whole list. And you know what's great about all of these? They can also be used with a person with dementia. So they're good for both of you. Books on tape, soothing sounds, coached relaxation, pamper yourself, neck rub, back rub, hand massage. Take a walk, sit in the sun, rock on the porch, pray or read a passage from Scripture, journal, cuddle, stroke a pet, have a cup of coffee or tea with that special friend, decaf. Pay attention to your personality. If you rejuvenate by being alone, seek solitude. If you rejuvenate by being with others, seek company. But take care of you so you can take care of other people. So, bottom line, learn how to breathe. And reach out and take care of somebody else, not the person you take care of. I hope today's been helpful to you. I hope I took you through a journey that made sense. I hope I've given you some tools for the journey, gotten you thinking about the journey, gotten you realizing this is a lot of work. But there's help out there. You're not in alone. And I will also tell you the numbers are growing. So you're even less alone than you think, and it's going to go nothing but up. So the more we know, the more we share, the better we can care. So thank you all for giving up your day and coming in. Appreciate it. Thank you.